Okay, good morning, everyone. Um, Welcome to the this morning's panel discussion, co-organized by Citizens Health Initiative, CITRA, UKM, and Vital Signs. Let me begin by situating the theme of this morning's panel. Okay? That is taxation, public finances, and healthcare funding. In the context of what transpired late 2024, okay, to be more specific, December 2024, right? You'll recall there were announcements from various insurance companies and their associations, okay, about hefty increases, okay, in health premiums, ranging from 40 to 70%, okay, if I recall correctly. Okay, which would be introduced the following year, 2025. Okay. And that, of course, led to quite an uproar, okay, among policyholders. Okay. 3.5 million, maybe not all, okay, but quite an uproar. Okay. But in the immediacy of the firefighting responses, okay, to that widespread unease, okay, from Bank Negara, KKM, Health Ministry, okay, Ministry of Finance, okay, as well as even from the Parliamentary Special Select Committee on Health, Public Accounts Committee, okay, and mutual recriminations, okay, between the Association of Private Hospitals of Malaysia, APHM, and LIAM, okay, the Life Insurers Association of Malaysia, okay, and of course, okay, from consumers and patient advocates, of whom reportedly about 350,000 okay, eventually dropped their insurance policies because they considered it unaffordable, okay, with the price increases. Okay. But in the immediacy of those responses, I felt at some point that, and the quite extensive and sustained media coverage right up until now, quite remarkable, more than a year later. Okay. But in the immediacy of those responses, I found it necessary to step back, okay, a bit, okay, and ask myself some underlying questions, okay. Most particularly, what do we need insurance for? Okay? Yeah, what do we need insurance for? Okay, and I think the answer for many citizens, okay, is not the only factor, but then a major factor, okay, is that there is a felt need, okay, for a contingency plan, okay, for accessing timely hospital care when an urgent need arises, okay, whether for the policyholder or family members. Okay. So, which directly leads to the elephant in the room, okay, that is the state of our public healthcare facilities. Okay. The elephant in the room, underfunded, chronically underfunded public sector healthcare, under-resourced, understaffed, crowded, overcrowded, long queues, waiting times, okay, for procedures, investigations, as well as consultations. Okay. So this was an issue which I and many colleagues felt was not given sufficient media coverage, okay, in the responses, okay, to those hikes in insurance premiums, okay, and hence, okay, this morning's panel discussion, okay, which focus specifically, okay, on that elephant in the room, okay, the chronic underfunding of public sector healthcare, in particular KKM, okay, Kementerian Kesihatan Malaysia. Yeah. So many people, when they first saw the title, so what's its relevance? I mean, this central focus, okay, in the context of discussion of health systems reforms and its financing. Okay. So I hope that contextualizes, okay, the main reason, okay, why we are having this panel this morning. Now, okay, so KKM's chronic underfunding. Okay. Khairi Jamaluddin, okay, was the first health minister, even during his short tenure of 2 years, okay, was the first health minister who publicly acknowledged, the chronic underfunding of KKM, okay, and went on to make public declarations, of his commitment to seek to double federal healthcare allocations, to KKM within 5 years, Yeah, he was the first health minister. Prior to that, whenever issues about healthcare financing, public sector healthcare financing was brought up, a succession of previous health ministers, as well as senior ministers of senior staff, of KKM, the constant refrain was that, we are subsidizing public sector healthcare to the tune of 90% and upwards, because what KKM collects, in terms of user fees, amounts to only 5 or 10%, 5 or 10%, of actual operational costs. In other words, the subsidy, the de facto subsidy was about 90%, and with this high subsidy rate, it's not sustainable. It's not sustainable. So something has to change. Something has to give. But that's on reflection. That's actually not a very appropriate metric. Not very informative. The proper metric, is the healthcare allocations. In particular to KKM, as a percentage of GDP. GDP, of course, measures the value of the productive output, of the country's economic system, goods and services, and what portion of that, is being allocated, to healthcare. That is the relevant metric, and on that score, by that criteria, you can see that there's a point. You can see the on that graphic, this figure is taken from the health white paper that Khairi Jamaluddin, KJ, shepherded, initiated, but it was eventually passed after he had departed the health ministership. But he was the one who initiated it and put in a lot of work. So these are figures, from WHO's Global Health Expenditure Database. Now the top row, those columns, they're fairly legible except for the middle column. The light blue column is for Malaysia. The dark blue column is for UMICs, upper middle income countries, of which Malaysia is categorized currently as UMIC, upper middle income country, and the one in beige is a high income country, average. So if you look at the top row, total health expenditure as a percentage of GDP, these are figures from 2019. In that year, Malaysia total, public plus private, Malaysia 4.1, UMIC average 7.4, HIC average 8.8. That's total national healthcare expenditure. Now if you look specifically at government health expenditures, the bottom row, again for 2019, the government expenditure was 2.2% of GDP, 2019. The UMIC average was 4.4%, and the HIC average 6.4%. Oops. Okay, now that was for 2019. More recent figures from 2022, although, a slight caveat here, this was during the height of the COVID pandemic, so they may be slightly atypical, but nonetheless, the point I'm going to make is still valid. These are figures from, this slide is borrowed from Debbie Moyhead, who is the senior health economist at WHO's Cyberjaya office, which covers Malaysia, Singapore, and Brunei. So this was from a recent presentation that she did a few months ago. Figures for 2022. If you look at the that row with the finger pointed at it, again the government health expenditure, 2022 for Malaysia was 2.2% of GDP. The UMIC average for that year was 3.1%. And the in this case, it's listed as OECD countries, rich countries. Okay, a proxy for Higg average. Okay, was 8.3%. Now, Debbie made a very important point. Okay, that Malaysia is on the verge of joining the ranks of the high-income countries. Right. So actually, we should be looking more at Higg average, which Malaysia will very soon join. Okay. So of course, 8.3% again was the average for Higgs again. For Higgs again, and Malaysia might be on the lower end again of the distribution for Higgs again. Okay, you'll be on the upper end of the distribution for UMIX and on the lower end of the distribution for Higgs. So you can imagine somewhere in the region 5, 6, 7% thereabouts. Okay, so our 2% average again should be set against again what it should be again in the region of 5, 6, 7% again. Again, the average for Higgs again was 8.3%. Now that really drives home again the extent again to which we are underfunding again government, public sector healthcare. Now, what I've shown you are figures from 2019 to 2022. If I have time series data to show you, okay, over the last several decades, okay, it's been about that, relatively stagnant. Okay, in fact, for many years, it's below 2%. Okay, certain years, especially during the COVID years, okay, government had no choice again but to bump up public sector spending. Okay, but it's been hovering around 2%, the lower twos, 2.1, 2.2, okay, in many years, even below 2. Okay? All right. Now, notwithstanding, okay, the fact that we were spending in the region, in the region of 2% GDP okay, on government healthcare, okay, in the early decades after Merdeka, okay, the burden of disease was characterized largely by infectious diseases, communicable diseases, and malnutrition. Okay, so in that situation, okay, even with that very modest 2% GDP, okay, but with well-chosen low-cost public health interventions, okay, you could actually be quite impactful okay, in terms of population health. Okay, especially our rural health service, which is an underrated achievement, okay, that we have never properly recognized. Okay, but rural health service, in fact, it's been said that Malaysia had the best distributed primary healthcare system, largely not just urban areas but also rural areas. Okay, after Cuba, the second best geographically distributed primary healthcare system in the world, second after Cuba. I think it's still the case that close to 80+% of our population live within 5 kilometers or 1 hour's traveling distance of static primary healthcare sector. That's very good. It's even better in the United States and probably Australia as well. Okay, it's something that we should be quite proud of. So in the rural health service, so in those first few decades, after Merdeka, with that kind of disease burden, largely communicable and malnutrition, with these kinds of intervention, village midwifery, bidan kampung, as part of CHA, vaccine preventable childhood ailments, attention to that, tandas curah, porflush latrines, otherwise known as the CITRA bowl, CITRA in Kedah, in the Muda irrigation scheme. I suspect there was probably a factory, in Kedah, in CITRA, which was manufacturing those simple latrines, and they were installed, in many kampungs, Big porflush, you don't need a connection, to a sewage system, So tandas curah or the CITRA bowl, the applied food and nutrition program, potable water supply, environmental sanitation, control of communicable disease. And if you want to talk more generally about social and environmental determinants of population health, include things like rural access roads, rural electrification. These are very important, impactful interventions. We don't think of them as public health interventions, but and even more. Perhaps even the progressive redistributable aspects of the new economic policy. With aspects of it did have very positive impacts on population health. So, but that's the rural health service in the first few decades, okay, of the after Merdeka, okay, and the consequences of that you can see, okay, in this graph, okay, that's life expectancy at birth, okay, for males and females, steady improvement since 1969, okay, up until the 2015, the latest year that this graph had the data for, okay, and child mortality rates under 5, infant, prenatal, neonatal, steadily improving, quite creditable, okay, improvements in population health, maternal mortality ratio, steadily declining, okay. But okay, in the more recent decades, if you look at life expectancy at age 60, okay, that means that if you survive until age 60, okay, what is your remaining life expectancy? Now that's where our very unsatisfactory situation, okay, becomes very obvious, okay. Okay, this graph graphs it over 1980 to 2012. Okay, these are for males. I'll show you the one for female. Okay, the comparator countries in this graph. Okay, Japan, Malaysia, Australia, Singapore, Hong Kong, New Zealand, Taiwan. Okay, the one right at the bottom is Malaysia, unfortunately. Right, and you can see that from 1980 onwards, okay, there's a divergence, still increasing, okay. You visually measure it roughly agak-agak, okay, it's about 5 years. We are lagging about 4 or 5 years, okay, in life expectancy at age 60, okay, compared to countries that we used to be on a par with, okay, maybe about four or 5 decades ago, Singapore, Taiwan, Hong Kong. We are lagging 4 to 5 years, okay, in life expectancy at age 60. That's a lot, okay. Yeah, this is really population health evidence, okay, of what is almost certainly, okay, the consequence of our changed disease burden, okay, our current epidemics of NCDs, okay, non-communicable diseases. Our disease burden has changed quite a bit from the early post-Merdeka decades, okay, from communicable, largely malnutrition, okay, to one which is increasingly dominated by NCDs, okay, hypertension, cardiovascular disease, cancers, mental health, okay, NCDs, okay. So these are the two main points I'm stressing again. Firstly, okay, our chronic underfunding. I don't think anybody disputes that. The health minister, we had a conversation early on again. Everybody, health ministry, all agree. Everybody, pretty much the entire government agrees. Yeah, we are at this point again that we are in comparison with other countries. Okay, we are grossly underspending, especially for the public sector, and the consequence of that spending, because again, to deal effectively with this ongoing epidemics of NCDs, again, most importantly, the coping response requires primary care-led, okay, promotive, preventive, comprehensive primary health care, okay, with referral linkages, okay, to high levels of care. Okay, all of government, all of society, okay, responds, okay, to these epidemics, and for that, again, 2% of GDP can't cut it. It can't cut it, okay. That might have been you could struggle by with that level of allocation, okay, in the early decades after Merdeka. Now, okay, with these kinds, I don't have slides to show you to emphasize, but many of you have already heard about it, about how within the ASEAN region, Malaysia stands out, okay, as having the highest prevalence of overweight, obesity, diabetes, okay. Debbie was mentioning in a presentation a couple of months back that women suffering breast cancer, okay, about 70% of them present at stage 4, okay, which means very poor survivability. Okay, so we have inadequate screening, because you see, in the case of communicable diseases, okay, Those are what the clinicians call acute episodic self-limiting. Oftentimes you don't even need antibiotic, okay? Just let your immune system count him, you know. Okay, but when it comes to NCDs, okay, NCDs once you're diagnosed with hypertension, diabetes, or you have cancer, or cardiovascular disease, okay, it's a lifelong condition, okay? Not cancer, but the others, okay? It's a lifelong condition in many cases, and you need a constant follow-up, okay? So you need a continuity of care, okay, with the referral linkages, okay, when it comes to that stage, okay. So 2% of GDP, okay, can't cut it, okay, for that, for public sector. Okay, this is a female life expectancy, same thing, okay. Diverging lag, okay. Okay, so now that I hope explains, contextualizes why, okay, the focus of this morning's panel discussion is on taxation, public finances, healthcare funding, okay? Because we want to get to grips with this elephant in the room which has not been sufficiently covered in the media, okay? It's chronic underfunding. Thankfully, it was acknowledged by KJ, okay, when he was a health minister. So the key aspects of this morning's panel discussion, again, will focus on overview of sources of government and public revenues, overview of sectoral government and public expenditures, declining trend of government revenues as a percentage of GDP. There will be a slide presented afterwards, okay, which will elaborate on that. And realistically, what sources of revenues can be additionally tapped for substantial increases to public healthcare spending? Okay? And if public healthcare allocations could be substantially boosted, okay, what should be the spending priorities? So these are not all the questions that we're addressing again, but these are some of the key questions that panelists and hopefully involving the audience discussion as well. Okay. Now to help us move things along, okay, we have a very distinguished panel, okay, this morning. Okay. I'll say a bit about panelists' background, but it's quite remarkable. The backgrounds, experience, and the expertise, okay, the combination, okay, of the panelists' backgrounds, okay, I think will provide us with some very useful insights, okay, fruitful discussion, okay. Prof. K.S. Jomo, okay, is a well-known development economist, which of course okay, spills over into development financing. Okay. Jomo was Assistant Secretary General in charge of the Department of Economic and Social Affairs at the UN Secretariat in New York from 2005 to 2012. Aside from that, he subsequently also held the post of Assistant Director General of the Food and Agricultural Organization in Rome, okay, which means, okay, that he has also been dealing with health, food and nutrition aspects, okay, of FAO, and by extension health, okay, in a development context, okay, developmental institution like FAO, okay. So he brings a wealth of experience, okay. He wears many hats, okay, but that's the one, okay, I think, which is for which we are especially thankful, okay, that he's a member of the panel this morning. Prof. Sharifah Ezat, okay, is a professor at here at the medical faculty in Department of, is it still called Community Medicine? Okay, Community Medicine. She is not only that, okay, a medical doctor, she also has postgraduate training, PhD in health economics. I believe you're a student of Prof. Syed Junid. Yeah, okay, who was a prominent health economist, also a medical doctor. He used to be here at UKM, now at IMU, I think. Yeah. So now, in addition to that, okay, Sharifah is also wearing another hat as the Dean of Liberal Science Studies at UKM. I found that very interesting. I'm a graduate of American universities, and we're very familiar with the notion of liberal arts curricula, okay. But this is the first time that I came across liberal science studies, okay. Very interesting, okay, which I which kind of a mirror image of liberal arts curricula in the United States. Okay, and what I understand from it is that it's a program, okay, with a curriculum of integrative sciences. Okay, integrated sciences, and perhaps even extending to social sciences. Okay, with required credits you have to accumulate in social sciences and humanities. Arts and humanities. Actually, it reminds me very much. I went to a technical university, okay, and which was very well known for science and engineering, okay. But even so, okay, 25% of my undergraduate credits had to come from humanities and social science. So I think it's a fantastic idea, okay. And this is particularly relevant if we are thinking about all of society approach to NCDs, okay. That's exactly the kind of people, okay, with that kind of background that you need, okay. If you think in terms of the social etiology, okay, yeah, of communicable NCDs. Okay, that's the kind of person that you need. Okay, so that's Sharifah. Okay, Dr. Jeyakumar Devaraj. Okay, is is a physician, chest specialist, pulmonologist. I think they call it, right. Yeah, chest specialist. Okay, who worked many years in KKM. Okay, but like the other panelists, okay, he also wears other hats. He's currently the chairman of Parti Sosialis Malaysia. And he's been in the forefront, okay. He was a two-term member of parliament for Sungai Siput, okay, and has been a forefront both in parliament as well as outside of parliament in leading a fight for equitable access, okay, to healthcare, okay, for Malaysian rakyat. Yeah. So Kumar brings a lot of experience to this discussion. Dr. Azraai Nasruddin, okay, is our fourth panelist. He's an endocrinologist, okay, served many years with KKM, okay, was until recently at the Puteh Hospital, endocrinologist. But he also, okay, wears another hat, okay. He has the invaluable combination of being not just on the front lines, okay, dealing with NCDs, okay, as a clinician, okay, diabetes, okay. But he was also seconded for 10 months as a special functions officer to the Ministry of Economy, okay, to the Minister of Economy, okay, which the Ministry of Economy was the lead ministry, okay, which was charged with the responsibility of drafting the 13th Malaysia Plan, okay, 2026-2030. And Azraai was very much involved in the health sector inputs, okay, into the 13th Malaysia Plan. So he combines his experience in clinical medicine, okay, with health in a development planning context, or health planning in developmental context. Okay. So and then, okay, Manvir from Vital Signs, okay, will be co-moderating it along with me. I didn't introduce myself. I'm Chee. I'll be moderating the first part of this morning's session, which is my role mainly is to facilitate an interactive conversation, okay, among the panelists. Okay, I'll jump in once in a while. Okay, this will go on for about maybe an hour and a half. We'll take a 15-minute break. The second part of this morning's session will be moderated by Manvir. Okay, that'll be the Q&A from the audience. Okay, all right. So that's the plan for today. Okay, this is actually at the end. Okay, it doesn't have to be today. Okay, but in the following few days after this event, okay, we're very keen to get feedback from audience, both in person as well as online, through the live stream. Okay, so there's a QR code that can be scanned. You don't have to scan it right now, obviously, okay. But the raw footage from this live stream will be posted at the Facebook pages of UKM Medical Faculty as well as CITRA, okay, because this is being live streamed to Facebook, okay. So you'll be there for 30 days, okay, after today's event, and so you'll be able to see that QR code, okay, on the raw footage, and we'll also make sure that that QR code is circulated to participants in person as well as remote participants. Okay, we're very keen to get your feedback, okay, about today's event. Okay, with that, let me then proceed, okay, with a few questions, okay, which will start the ball rolling, okay, and initiate this conversation, okay, among the panelists. So the first, if we backtrack it, okay, probably useful point of departure, okay, would be for us, for the audience, okay, as well as for many of the panelists, okay, to get a sense of a broad overview, okay, of what are the sources, the main sources of revenue for the federal government. We're talking just of federal government. What are the main sources of revenue for the government? And then what is the sectoral distribution, okay, of government expenditures? How is it being distributed among the different ministries? Okay. And then leading on to a subsequent discussion on the declining trend of government revenues as a percentage of GDP, which is sort of the underlying circumstance, okay, which helps us understand why our public sector healthcare expenditure, okay, has been remaining stagnant, okay, as a percentage of GDP. Let me just share an anecdote at this point, okay, before I start the discussion. 2019, I was moderating a public forum at the University of Malaya, okay, and one of the panelists was our longest-serving Director General of Health, okay, Tan Sri Dr. Abu Bakar Sulaiman. Okay. So I had the opportunity to ask Tan Sri, okay, Tan Sri, during your long tenure as DG, okay, what were the main obstacles that you encountered, okay, on the many occasions when you requested through your health minister for increased allocations to the health ministry, to KKM, okay? He said, Chee Khoon, invariably, okay, at cabinet meetings on other occasions, okay, there will be somebody from the Treasury or the Ministry of Finance reminding the KKM delegation, okay, that the federal government considered it very important to maintain an attractive investment climate for foreign investors, for FDI, okay, and as part of that, okay, it was important to maintain very low taxation regimes, okay, corporate taxes, also income taxes, okay. Now, of course, that has implications for government revenues and the fiscal capacity of the state, okay. So, basically, the message to Tan Sri was that we can't afford to spend too much, okay, on healthcare because we're going to keep our taxations low, okay, in order to be attractive, okay, to foreign investors, okay. We're competing with our regional neighbors and other countries, okay, for foreign investment. So that to him was a major reason, okay, why the health ministry, okay, was chronically underfunded. So let me then call upon, I think among the panelists, probably Jomo, okay, Kumar, from your experience, okay, in the parliament, okay, raising this kind of question, probably in budget debate, okay, government allocations, what's the sectoral allocation, okay, among different ministries, okay. Can you give us an idea, okay, of what are the major sources of government revenue, okay, and the major sectoral expenditure? Two panelists and Chee Han. Dr. Lim Chee Han is a senior researcher at the Third World Network, okay. And he has actually done a great deal of research and tracking, okay. I thought he was mainly looking at budget allocations to Ministry of Health, but he now informs me that he's looking at it more generally, revenues, sources of revenue, as well as sectoral expenditures of other ministries as well, okay. And within the ministry, looking at Malaysian national health accounts, how they're being used, allocated within the ministry itself to staff salaries, pharmaceuticals, hospitals, primary care, etc. So perhaps the three of you could help us get an idea, okay, of what the overall picture is like. And who would like to start? One, three of you. Kumar? Yeah.
I know the least, so better go first. If you look at our budget for last year, is this coming through? You can hear? The budget for last year, the revenue is about 320 billion. So out of GDP of around 2.1 trillion. This is about, say, 16, 17% is what's the government revenue. And the sources of it, the largest source is taxes. Corporate taxes is the largest source. I'm not sure about the figure, maybe it's about 80 billion or so around there. And you must know that for Malaysia, our corporate tax rate has actually come down from 40% of profits in 1988 down to its current 24%. Of course, as Prof. Khoon is talking about how the ministry is trying to make us attractive for FDI. So from the beginning, we've been told by World Bank and IMF, be more attractive, lower your corporate taxes. So we have lowered, then Thailand has lowered because they're also looking for the same FDI. Vietnam has lowered, Indonesia has lowered. So all of us have been doing this. So I think now Vietnam is about our level, Thailand is about 20% only, and Singapore is 17%. So corporate taxes have come down, but it's still the largest amount. Personal income tax is less than corporate tax in terms of the amount, because only about, I think it's about 18 to 20% of working Malaysians pay taxes. I think you got to earn more than 3,500 a month to qualify to pay taxes. So Malaysians are low earners lah. Though the economy is growing, a lot of lower paying jobs. So only about 18%, 20% pay that. And Petronas is a major source lah, both from taxes, from dividends, from grants to the government. Petronas is a major source. Then of course you have sales taxes, the SST. I think it's about 35 billion. Isn't very big. You have SST, you have excise duties. Then you have revenue from government companies. Some government companies, the GLCs, actually give money to the government, but it's not a huge amount. So that's roughly it lah, And one last thing, our total government revenue is now about 16% of GDP. But about 35 years ago, it was about 30%, 28 to 30% of GDP. So the government, of course, GDP then was much smaller lah. Our GDP has grown a lot. GDP has grown about 20-something times in real terms the last 50 years. But the proportion of it going to government as revenue has halved. From last time it was 28%, now it's about 16%. Okay, I'll stop there and then...
Did you have any slides? You gave your slides to sign. You want to show any now?
No, I think, it's okay. I already said it, so... Okay. Yeah, let Jomo.
Chian, would you like to say something?
You want to show a slide? Yeah. Can you show Chihan's slides? Yeah.
Hi, good morning. 2 days ago, Khoon asked me to whether I can help enlighten or give a context of federal budget. Why are we running out of money? Why we cannot increase the expenditure for essential services and social welfare? So I'm going to show you where are the sources of revenue and what are the structural problems, and what are the current government plan in terms of fiscal policy, what are their concerns. So this has certain natural limitation on how much government can allocate budget for example, operating expenditure. All right, I'm from Tower Network. I'm a senior researcher, long-time health policy researcher, basically looking at healthcare financing and also in general government finance. Next. I didn't put. Next, can you? Next slide. Oh, here. It's not.
You're going to move it, eh?
Oh, here. Okay.
Yeah.
Okay. Sorry. All right. All right, I want to share with you the financial position, which is very important because we're talking about two parts. One is about income, the revenue. Then what are we going to do with the revenue is to have the operating expenditure to run our offices, the basic services. And for government expenditure, there are two parts, very important, you need to remember. It's about operating and then development. Under our fiscal law, financial law, operating expenditure can only be financed by our own income, our revenue. So we should not borrow just to cover our operating expenditure. It's not allowed. So you can see how the government, MOF or our finance ministry, want to push the limit, basically using our revenue to cover operating expenditure. So what to do with the development expenditure? We need the development expenditure to spur the growth of various sectors, to have the development, the proper national development. So you can see that after you minus the operating expenditure, usually the balance is very little. If you have, you can see it 2026, this year, you're only left with about 5 billion. It's not enough for development. Then naturally, we have to borrow. So you can see that the government allocate 81 billion for development. So this, you look at the overall balance is in the minus region, which is about 75 billion in deficit. In terms of GDP, is 3.5% of GDP. Why does it matter about deficit? Because government do have their target. They want to make sure by 2028, the deficit is reduced to 3.0. But very ironically, we actually have been there during Najib time. Until 2017, you can see that it's actually, we are at the region of about 3%. But due to COVID, which I think was necessary at the time to borrow more money to help people to get over the hardship at the time. So we left 2 years to reach a target, but I think it's very doable because for this year, it's expected to reduce to 3.5. So I think it's doable. That means, what does it mean? It means that government will borrow less money. So even for development expenditure, they will borrow less money so that they can achieve this target. So you don't dream of government to borrow more money to pay for more expenditure. That's one thing you need to know. Next, I want to talk about revenue. For revenue, there are tax revenue and non-tax revenue. These two large categories, which the tax revenue took about 75%. And then the non-tax about 25%, is one quarter. So out of the tax revenue, about half, is for the whole total revenue is from the direct tax. Direct tax means those income tax come directly under your name, which when you are income earner, you pay your personal individual income tax. That was about 12.7 in 2024, the actual figure. And if you look at the company, it's about 28.6% of GDP. And totally, the direct tax took about 52. Later, I will show you a longer timeline to see the trend. It actually plateauing at about 50% of the direct tax took about 50% of the total revenue of the government. One thing you need to look at is the SST. SST, you can see the proportion is climbing up, especially for this year after they have expanding the scope. So government will plan to will have their hope to have this SST providing more revenue for the coming years. But one thing also I would like you to see is that the individual income tax and then the corporate tax, in terms of absolute number, it's increasing by year. In terms of a proportion, also increasing in terms of a share of the total revenue. So even though we know that government is giving like more individual income tax discount or for certain category of income earners, and also keep the corporate tax low, but you can see the number is actually they're collecting more. So you can see the trend from 1970 until 2025 is all in the upward trends. So that means revenue is actually increasing year by year. Only during the financial crisis in 2008 and then the COVID, you can see a dip in terms of collection of the revenue. I'm talking about the tax revenue and also the total revenue. You can see the trend is basically similar. But if you divide by the GDP, you can see the share is actually dipping. Just like what Dr. Kumar said previously. Actually, after 2013 onwards, the share of our government revenue per GDP dropped under 20%. At the peak, you can see it's about 30%, 28%. Back in the 80s, yeah. And sure.
You're getting to a very important point about the declining government revenue.
Yeah.
Yeah, as a percentage of GDP. But before you get on to that again, one clarification again.
Yeah.
Maybe from my own confusion or lack of understanding, there's this notion of off-budget agencies. Okay, so the figures that you presented on the sources of government revenues. Okay,
Yeah.
the off-budget agent, I'm not sure whether they refer to things like Petronas, for instance. Now, of course, in your revenues, okay, you had PETA, okay, which is the petroleum industry.
Yep. Yep.
Okay. So we know that at its peak, okay, Petronas was contributing about 40% of the federal budget. Okay, it's come down quite a lot now. Now maybe about 20%. So can you clarify for us, give us examples of what are these off-budget agencies and whether the cash flows are captured by the statistics that you presented just now.
Yep.
Okay? Yeah.
So, all the money coming to the federal government is going to the consolidated fund. So, not just tax on the petroleum, but the petroleum company also pay royalty. So, those are categorized in the non-tax revenue. It's quite substantial. I think for the coming year, this year, they expect to pay about 3.2 billion for this year. Even though the revenue is already shrinking. I think I have the slide to show also in terms of the share of the petroleum revenue. I think the proportion is going to shrink. I think it's not, I don't know whether it's a peak or not, but in 2010, it took about more than 1/3 of the petroleum. So this includes the tax and also the royalty. Is what I mean. So for the coming year, for this year, it's only 12.5%. Means it's 3 times lower. Yeah, I think also in terms of the absolute amount, also smaller.
Okay, so aside from Petronas, can you give us other examples of OBAs, off-budget agencies, especially those which are significant sources of revenue? For instance, the GLCs, and GLICs, are they considered off-budget and which may not be captured in your figures of government revenues?
One knowledge for your knowledge, actually, whatever income the DBKL and the Labuan or Putrajaya earn also will come into the non-tax revenue. Yeah, so it can also come from the GLC. There's some, but I don't think it's a big amount because from the non-tax revenue proportion is already like 1/4 and quite some from the royalty. Quite some also from the government, the state government or local government, and So I don't know how significant are those. Yeah, because if you look at public financing, it's not just federal government. If you look at public, it's actually in another account book. It won't show up in the federal financial reports. So if you want to look at the role of GLC, you have to look at their individual financial statement because it's not reported here in the financial
So
statement.
they would not be included in
No,
the
unless the money
figures
go
that you-
into the consolidated fund, will pass through, then it will be captured. It will show. You have to report.
Okay, there's another thing which I've always been not clear about, okay, and this has to do with what is the protocol, okay, in reporting statistics. For instance, okay, in the 80s, of course, when the privatization really took off, okay, now something like Tenaga, okay, Tenaga in the past was LLN, Lembaga Elektrik Negara, okay. Now, before it was privatized, okay, we will be paying our monthly bills, okay, electricity bills to LLN, okay. Would that be counted? Now, of course, LLN is a statutory body, okay, it's not a proper government department. Or maybe a telecom, even better. Yeah, Syarikat, what used to be Telecom,
TMB.
Jabatan Telecom. Jabatan Telecom was a proper government department, okay. So our monthly telephone bills, okay, would be paid to Jabatan. Would that be counted as government revenue in the previous situation, okay? And once it's privatized as Syarikat SDM, okay, Syarikat Telekom Malaysia, okay, privatized, okay. So that's is it the case, okay, that our monthly bills, okay, when it was still a government department, okay, was counted as revenues, and
If
hence
they are still under as part of the government, under ministry or
Okay.
under certain jabatan, yes, it's
Okay.
counted. Any the money flow will be
LLN is a
captured.
bit ambiguous because it's statutory body.
Statutory
But
body
even
is
so,
different now.
because I mentioned this because it's a huge corporations. They are among the
EPF
biggest
is also
corporations
huge,
on the
EPF.
bursa. Okay, so if the privatization results in this different labeling or categorization of these revenue flows, okay, could that explain part of the reason why government revenues are dipping?
Actually, not all statutory bodies making money. Some
Okay.
some actually receive grants from the government to function. So you
Right.
can see that in the financial reports from the federal government that the government actually give grants to
Okay,
statutory
but whatever the
bodies.
case, okay, money that's flowing in, okay, from consumers, okay, from for electricity bills or telephone bills, the incoming money, incoming revenue flows, is that counted as government revenue?
If it's privatized, you won't see it in the.
Okay, but before the
before
privatized,
that, statutory body also you won't see unless they are part under department.
departments
yeah,
like Jabatan Telecom.
Yep.
Okay, okay,
Okay.
all right, okay, thanks.
All right. So I also like to share with you. You can see the trend since 1970. I would like to share. Want you to have the attention on the share of income taxes. So this how, the extent that we can get it from the corporates and the people. It's actually plateauing at 50%. Why I say so? It's actually quite a long time trend already. Since 2012 like that, you can see that the companies actually got a big jump. Probably Dr. Kumar can explain why. I don't know, but you can see that since that moment onwards, companies or corporates actually contribute more revenue to the government compared to individual taxpayers. So it's about 3 times more. And petroleum is going downhill. I mean, you can see that in 2025, it's only contributing about 6.1% in terms of tax. Yeah. This one I already show you. You can see that what is actually changing is the purple color one. It's a thing that you should see, because indirect tax means that you only pay tax when you spend certain things. It's taxable. Like if you have property, you have to pay the real property gain tax. Then it's called indirect tax because it's only when you spend the relevant categories. So SST itself will play an important role. And I wish to tell you that you can see there's a blue bump here. Indirect tax in 2015, during that time, 2014. Do you know why? Yeah, this one. It's because of the implementation of GST, suddenly government will have 20 billion more. And after that, it took actually years until 2023, the SST only can gain back to the same level of indirect tax. So like 7 years later, 8 years later. So GST was effective, although we say it's a regressive tax, especially to a lower income household or the middle income household. But it was effective. You can see the bump almost immediately. But it's also a reaction to the direct tax. Maybe people getting poorer, they got more relief. So you can see it's an opposite trend that time. All right, I'd like to talk about the expenditure. So what are the things that we actually very hard to move? For example, emoluments. Whenever government have more programs, you need to hire more people in a position to serve you. So every year you can see in terms of the money terms, absolute money terms, and in terms of the share is increasing. Retirement charges also one thing that government wants to rationalize. Now they're doing that with the help of EPF, so that the pension fund can be reduced or controlled. But still, going forward, at least until this year, it's still going to go increase. And debt services is one thing that the government wants to control. If we can reduce the deficit, that means in near future, coming years, these debt services charges can be reduced. So the purpose where I highlight is the thing that government can control, so that it can free up more money. Okay, and then one very substantial thing you can see the government is already doing is on reducing or removing subsidies. So from 2024 and until this year, it's about 7% share removed, or about 20 billion from the 67 billion in 2024 to about 50 billion this year. So this is where the government spare more room to spend. So what we concern is actually supplies and services, because when they have more money, then can pour into services and supplies, so you can get more medicine, more equipment to run the clinics and things like that. So that's what government hope to achieve. So you can look at it this way: what is under current government framework, what we can move about to give more money to the operating expenditure. Yeah, so you can see all the items I listed. So the government is trying to reduce the subsidies and hopefully can reduce the debt services charges in order to pay more for supplies and services, like buy more medicine and equipment and supplies and things like that. This can serve our patients, our people better. So this is one thing that government already can do. So in terms of the distribution of expenditure, I want you to look at the DE and the OE. So the operating expenditure is naturally bound by how much money we can receive as revenue. That one we cannot touch too much unless we have more revenue, so we can spend more. But DE is something that I believe if we want to redistribute, it's something that we can do. I still feel that MOH didn't get the fair share, the average share of the DE, because the average DE is about 23%, and MOH only got 12.5%. So I feel that there's a lot of things that we can do to help the MOH in terms of development. I think this can also increase the efficiency and improve the services. Maybe one thing is to look at, if the operating budget is very tight, very hard to do, DE probably is something that we can control, or maybe necessarily borrow certain amount of money to do the development where necessary. Just now, I have to point out to you that the Ministry of Health is the third highest budget allocated ministry after education and finance. So I think there's still some room to grow, and I think government have to get their priorities right. What is necessary, what is essential, they have to prioritize. So every year, the finance minister and health minister will tell you they got the record budget. It's true. If you look at the total number of total amount they got, it's every year higher. So you don't say the government getting less money. It's not true. They're getting more and more money, but is it enough? That's the question. So like I say, the Dewan budget is only 14.5%, but the general trend is about 23% or 22%. So I think there are some room to grow. I think it's also necessary. Probably in this room we can look at how to help the MOH. If the OE budget is already have a constraint, I think why not looking at DE, what we can help with the health ministry. So there are some items in the DE I think is very helpful. For example, the one in the red is the hospital facilities. You can upgrade, we can repair, and also to have more like IT upgrade, so that this can improve the service delivery efficiency, and I think everyone can be more comfortable and so on. And I would like you to look at the purple one, which is the training part. Now we complain that certain doctors still waiting for the training opportunity to be a specialist. I think there's some natural constraint there about monies, but you can use DE to do all that. Yeah. And lastly, the black box is the public-private partnership. That one maybe sometimes a lot of times is one-to-one, the JV and all this. It's a way that you can raise funds to do certain projects. And probably government can also think about that. If you can have more money come in and partner with other people to deliver certain, even like buy certain healthcare services, is doable from the DE side. That's all I want to share with you. Hope this can give context about later on, like which revenues we should increase and how we can help the MOH get more budget and to do what things. Yeah. Yes. Oh, all right. Yeah. Yep.
Do you have the what they call the growth rate of medical spending? I think that's more important than just looking at the level of spending now. Do you have the growth rate projected for another 10 years?
Yeah, I did the statistic. I didn't show you, but I think just now in Chee-Khoon's slide also I can show that the growth rate of our GDP doesn't equate to the growth rate of our budget. Yeah. So it's below our GDP at times. Even sometimes the GDP we got more money, but you don't see the similar increase for the health budget. Susah lah. I don't know lah. Yeah. So there's no correlation. I also find out whether when the government got more money, does it mean that MOH will get the similar proportion of increase? Actually, no, it's not like that. So there's no correlation at all. If the government get more money, they will give you more money for MOH. It's not. There's nothing like that. Yeah.
So you're saying the 6.7 billion is used for capital expenditure to maintain the 200 hospitals and all the clinics in Malaysia?
Not. I mean, operating budget is to keep the operation ongoing. Yeah. The development. So you build more.
So when you divide it by the 200 hospitals and the 200 clinics, it's only a trickle actually.
It's not all the budget is for that. I think just now there's a line item to show what is the amount given to like build the new hospital and upgrade the facilities. That's the amount they have for that year.
From a very layman point of view, to maintain equipment in the hospital. It's broken down. Is that considered capex?
Yes, you need to buy.
Yes, repair means they use the development, yes, to repair, correct. And it's not average equally distributed, it's by case. Yeah, by case, yeah.
Sorry, can I ask your last slide? Perbelanjaan sebenar actual spend is like 2% of the anggaran. Are you saying that they got allocation and didn't spend it?
The DE one, right? Budget. Yeah. I couldn't go back to the slide. You want? Sure. Yeah. Usually, for example, for the hospital, you need more years to build. You probably need 5 years, and for one hospital, probably it's about the previous slide. Okay. Next slide. The next slide.
Oh, you want to?
Yeah. Next. Look, you say.
If I was MOF, then why would I give you more money if you're not even spending the money you've got?
Yeah, this is the total anggaran. For example, to build hospital baru, about 5 billion. But they won't give you in 1 year. You have to, because building hospital take years, so they break down.
It's actually for the total project duration, and the spending is by year.
This is the budget for this year. This is the budget for this year. This is the amount. But this is the total amount promised to spend for this purpose. The hospital Bahari, probably they break down into 5 years or more phases. So this effectively, this is money allocated for this year. Yeah, so it's about 820 million, right? Yeah.
So they're still underspending.
I don't know how long the hospital construction can take. Yeah, so what it matters is the budget for allocated for this year is that amount lah. They get the total sum is for the more long term future. That's the purpose of development expenditure is not for the current use. It's for long term. They can phase out into different stages, different years. So that's how it goes. Okay.
Can you put on the slide?
Thank you.
Thanks, Ian. Yeah. We may still have to call on you. Yeah. Okay. I think unfortunately, I think Dr. Lim has left, okay. But he raised I think this is the point that he was getting at. And it's a very important point, okay. It actually underlies, okay, this dilemma of stagnant expenditures as health allocations as a percentage of GDP. Okay. Now, this is a slide that came from a conference presentation that Dr. Yabuya and I presented again in 2019 at a summer conference again in Boston. And you have to look at these 3 graphs again, collectively, okay, to get the essential point, okay. The first graph on your left, okay, is MOH expenditures, okay, going from 1980 to 2016, okay, as a percentage of federal government expenditure, okay. So KKM expenditure as a percentage of total federal government expenditure. And you can see that between 1980 and 2016, it went up from 4.4% up to 9.2%. So as a percentage of total government expenditure, actually it's been going up. In the graph over on the extreme right, again, the line in red, again, orange red, again, is the expenditure, okay, in absolute terms, okay, KKM expenditures, again going up from 1980. So both in terms of absolute amounts as well as a percentage of total government expenditure, it's actually been going up, KKM expenditures, okay. But the problem is that if you look at the middle graph, okay, there's a federal government revenue as a percentage, okay, of GDP, okay. it's been plummeting in 1980, okay, from 27.4% to 15.1% again in 2016. Okay. So even though KKM expenditures have been going up in absolute amounts and as a percentage of federal government expenditures, okay, it's been going up. Okay, but because federal government revenues have been declining steadily between 1980 and 2016. If you look at KKM expenditures allocations as a percentage of GDP, it's been very stagnant over the last several decades, going back 50 years and more. In fact, post Merdeka was even below, much of the time was below 2%, and hovers around 2%. During COVID, jumped up and now settled down to about the low twos. Okay, so that is the issue. So when you look at that, our public sector expenditure, healthcare expenditure as a percentage of GDP, compared to international norms, UMIX, and increasingly HIC is what's relevant to us. We are grossly underspending. Now increase added money won't solve all problems. But if you don't have substantial increases in healthcare allocations to KKM, public sector, I don't think you're going to be able to have an impactful response to our current epidemics of NCDs, our major health challenges. Okay, any further? Huh?
I just want to make a couple of quick points because a lot has been said. And this is not really on the empirical issues involved, but I think it's important for us to look at the larger context of government revenue as well as government spending. If we look at government revenue, Malaysia had a very transition from a colonial government to a post-colonial government, and basically what you had during the colonial period, very little taxation of the foreign companies which were operating in this country. Just to give you a hint of how significant Malaya was, colonial Malaya was, to the British Empire, you will find that during that time, during the half decade after World War II, 70% of the sterling, of the contribution to the sterling zone in terms of export earnings came from Malaya. 70%. Now, to get a sense of it, Britain was devastated by Hitler's bombing London. They bombed not only the cities, but they also bombed the factories and so on and so forth. But this was how important Malaya was. So 1947, the entire South Asian subcontinent got independence. But what is now Malaysia did not get independence in 47. This was how important it was. You couldn't let go of it because it had to save the empire. Now, also very importantly, although export earnings from Malaya were making a huge contribution, the actual income tax coming from Malaya was actually very, very low, because this was the general attitude of the colonialists in all its empires and so on. Whatever little was collected was used mainly to provide some infrastructure, some basic services in order to maintain the empire. So everybody here knows that the first railway built in Malaya was from Taiping to Port Bell. Why? Because you needed to make money from the Larut mining area. You needed to get the tin out, and you needed that. And tin ore is very heavy, so you needed to build a railway to take the tin ore out. So I just want to give a sense of this. During the 20th century and even late 19th century, you will find that the main taxes were collected in the Strait settlements and later in Johor. What were the main sources of revenue? Number one, opium. Number two, alcohol. Number 3, gambling. Number 4, in Johor, number 4 was prostitution. Okay, the government actually collected taxes on prostitution. So this gives you a sense of how significant these taxes were, but it also, we have to look at the flip side of it, how irrelevant the other taxes were. So this is very important for us to understand. So when we accept this basic framework of budgeting in the post-colonial period, after independence, you basically have a very low tax base in terms of direct taxation. Now later on, the taxes were added in the post-colonial period, initially under Tunku, but the bigger increase was under Tun Razak. Tun Razak basically increased the taxation, and he also increased spending. Now, this is not the time to get into the story of what happened during this period, but it's important to recognize that during the 1960s and 1970s, there were tremendous achievements of the health system, given the level of income in the country, and we were considered to be among the top 3 in Asia. Why? Well, it was mainly because of very simple, low-cost interventions, such as, for example, the introduction of the Bidan Kampung. Okay, it was left to people like Dr. Muhammad Said, who later became the Menteri Besar of Negeri Sembilan. His wife had been trained as midwife in the UK, and when he basically they basically introduced this idea. So the pioneering doctors, Malayan doctors, okay, basically introduced a lot of these interventions which made a huge difference, and many of them were preventive. Rather, if you look at the kinds of articles which were written by the young doctors and so on, who were trying to address, they were addressing problems such as yours, such as various NCDs, various nutritional deficiencies, and so on and so forth. Now, basically, I would say, and people often say, oh, this increase of taxation is very bad for growth. You must keep taxes low. Well, was that true? The period of highest growth in the history of this country was actually the period of the 1970s, Tun Razak and Tun Hussein. Okay, this was a period of highest growth sustained over a decade. Okay, so this claim that when you tax you cannot grow is actually a false claim, which was popularized by a man named Arthur Laffer. Okay, I used to say it was a laughable idea, but unfortunately he was very influential. He was able to influence Ronald Reagan, and those ideas spread to this country as well. They spread around the world. They were discredited even within the Reagan team. There was a chairman of the Council of Economic Advisors for Ronald Reagan named Martin Feldstein, who used to teach at Harvard, still teaches at Harvard, I think. Martin Feldstein actually didn't want a renewal as the chairman of the Council of Economic Advisors. Instead, he went and wrote a paper basically pointing out that the claims made by Arthur Laffer were wrong, false. But I can tell you that right to this day, and many of you have probably encountered it, many people will tell you, oh, you cannot tax the rich because the rich are the ones who invest. If you tax the rich are not going to invest. Just to give you a sense of the period of highest growth in the US was under a man named Franklin Delano Roosevelt. And during that period, the highest tax rate for the highest bracket was 94%. I mean, 94%, something you cannot even imagine today, right? But that was the kind of tax rate which was introduced by Roosevelt. And similarly, you have very high tax rates in Europe. Now, for those of you who are inclined to think about the political ideas, now when you think about what is happening in popular culture, okay, many of you have heard of a musical from America called Hamilton. Okay, yeah, it's about a guy who was basically born out of wedlock, but who basically was very important. He led he was the Washington was very impressed by him because he was the one who lead the war and so on and so forth. But he created the institutions of the United States, and basically including the tax institutions. And this is very important because these institutions were the first institutions of what people now would call national liberation. After you have your independence, what kinds of institutions do you introduce? So tax institutions are extremely important to think about in terms for the independence of a country. And this was, and so when we think about Hamilton, this is important. But when you think about the UK, who is the most popular person besides Winston Churchill? And Winston Churchill's heritage is a very controversial one. Okay, he was quite happy for people to die when 3 million people died in Bengal during World War II. His only concern was that Gandhi had not died. That was the kind of comment Churchill made. But who is the most popular? There is now a musical in West End in London called Nye, N-Y-E. And who is it about? It's about Aneurin Bevan, the man who created the National Health Service. Okay, it becomes a symbol of ordinary popular culture. So it's very important for us to recognize that, in fact, these kinds of institutional changes which are made can have huge consequences, so much so that people come to appreciate it. Now, of course, as we know, NHS today is a shadow of what it was. But I think it's important to recognize that this increase in taxation during the 1970s was reversed from around 1984. And of course, the new finance minister then, who replaced Tunku Razali, was the late Tun Daim, and he basically started emulating what Laffer was recommending, reducing the tax rates, making the same arguments as were being made by people like Laffer. So the tax rates began to go down, and so the trends which Dr. Kumar and Dr. Lim referred to are actually partly a result of this. And every finance minister, even after Tun Daim, was trying to see how much lower you could reduce the tax rate. Because when you reduce the tax rate, what happens? These investment magazines will say, "Oh, you are finance minister of the year," that kind of thing. These are the kinds of. So there are a lot of incentives, perverse incentives, to encourage this kind of behavior, which is actually bad for the economy. Now, looking at spending, earlier I mentioned that this period of 1960s and 1970s was a period when you actually had considerable progress in terms of health spending in this country. In 1981, 45 years ago. This today is the second time I'm coming to this faculty in UKM. The last time was in 1981, because I was teaching at UKM at that time, and we organized an event. And the person who organized it was the Deputy Dean, Dr. Nasir Hashim. And we organized an event to look at the Rajkumar Commission report, which recommended certain reforms during that period. And the person who spoke on behalf of that commission was actually Bakar Sulaiman. Okay? And Bakar Sulaiman basically came here to the old campus next to KL Hospital, where he basically defended the recommendations of the commission he was part of. Now, those recommendations actually were very, very interesting. And I think it's still worth revisiting, although, of course, with the passage of time, some of them are less relevant. But what have we seen since then? During the 1980s onwards, we saw a big trend towards privatization. And this big trend towards privatization has also meant the big increase in price of medicine and sometimes related medical equipment. Okay, this is an issue which is quite important, because if you look at the people, for example, who are most influential in relation to President Trump's administration, they are often referred to as the tech bros. The tech bros refer to people who have become billionaires who are really related to two fields, primarily with information and communication technology applications, including AI, but secondarily and no less and not unimportantly, the pharmaceutical companies. So the big pharma is basically has a huge stake in this, but they're also some of the new equipment and so on and so forth is also important. So the what's his name, the member of Trump's cabinet. There are even members of Trump's cabinet who have made their fortunes in this. Now, together with this, there was an alternative trend. There was an alternative trend to promote the use of generics and so on and so forth. It was led by the late Zafrullah Chowdhury, who later led the People's Health Movement. But there was, and we have seen a whole number of pharmacists and chemists, mainly from India, but also increasingly from Bangladesh, who have, for legal reasons which I won't go into right now, who have basically been developing these generic drugs. Many of these drugs are actually can bring down the price, but what happened was that in 1995, the World Trade Organization was created, and they pushed through a legislation which was not really scrutinized and subjected to much negotiation and debate. And that was something called TRIPS, Trade-Related Intellectual Property Rights, which have basically given monopolies to any kind, and you can evergreen these monopolies by claiming that you're adding some new thing and some new innovation and so on and so forth. So a monopoly right, which is supposedly for say 25 years, can be extended indefinitely in different ways. Now, this is not only happening in pharmacy, but it's also happening in many others. The point I'm trying to make is that these choices, particularly the choices as far as getting revenue is concerned, as well as expenditure, are political choices. They are not simply choices which are made because of economic conditions and so on and so forth. These are very conscious political choices, often dictated or at least influenced by international trends, but also by regimes, national regimes which choose to support these kinds of things and so on and so forth. So these are some of the huge issues at stake, which I think are important for us to look at in terms of spending trends. So the trends which Professor Chan and Dr. Kumar and Dr. Lim have highlighted are trends which are the result of these decisions made in 1984, as far as the Malaysian budget is concerned, or subsequent decisions. All these decisions are being reinforced. The point is that you can change these things. And this is precisely why I think it is very important that initiatives such as this become very, very important, because very often people get lost in a lot of the details. They lose a sense of historical perspective. They lose a sense of there being alternatives which are possible, that things can be different, and there are choices which can be different. I think it's very important for us to recognize this.
Yeah, can I continue with that as well? Yeah, thank you very much for the invite, actually, Prof. Chan. I think Prof. Komo has touched on the historical perspective, and how transitions and taxes has played a role in the development of healthcare in Malaysia as well. Following up to that, coming from the healthcare perspective, I think a lot of us from public health and so forth, I would like to highlight on certain positive aspects of our current Ministry of Health, with all the issues, with all the declining, budgets and things like that. We have done a lot for the country. I mean, healthcare has, not me, but healthcare has done a lot for the country, given the small budget and so forth. Let me just show you some of the data. I mean, I don't have slides, but just let me tell you some of the data. If you look at our Human Development Index, which is one of the index that we use as a generic figure, it's a composite of healthcare, it's a composite of education and income and so forth, literacy rate, our health HDI. So that is considered good. It is always on the rising perspective. That means the transition is going upwards. So it shows a good HDI as well. Of course, if we compare this with OECD countries or very high income countries, we must know that we are considered the global south. You compare this with global north, it's a totally different background countries as well. So our HDI in relative, it is considered quite good. Our life expectancy is increasing, right? If you compare this with certain countries like Japan, of course, is probably not comparable, but we are on the rising side. On the rising side. Compare this if we are in the colonial areas, we might just live up to 50 or 54. For males might be a bit lower, and females, but now we live to almost 70, 80 plus. If you look at the recent 2024, 25, so it's almost like 80 plus. So we live to a so-called a ripe old age, and this is why Malaysia is considered going into an aging society. If you are not stable, you will not reach an aging society. So this is one good point for Malaysia. We are reaching an aging society in one sense. The second part is that all of the healthcare in Malaysia is governed by the biggest, I would say, healthcare provider in the country is Ministry of Health. And they have allowed a dual healthcare system. One is the public and another one is the private. We follow the colonial state, which Prof. Jomo had mentioned, NHS. So one is the public and one is the private. Both are soaring upwards, not only in the sense of budget, but also the private healthcare is gaining a lot of momentum in our society. There's plus point to that, there's negative points to that. Not all people can access private healthcare, but in some way the upper middle income and also the higher income would actually go and seek healthcare and access healthcare in the private. And for some of the private providers, when we talk to them, they say that they cannot cope even with that restrictions. Even with the, only the high income can actually manage, or they are insured, or they are employed by some form of provider payment scheme. With that as well, they cannot manage. There's so many patients coming in the private sector as well. So what does that mean? It means that without the private sector, the public sector is going to be highly burdened. And we need the private sector to work with us. And this is where the insurance later on will come in. The third part is that Malaysia is under the universal health coverage. I think this is one point that I think Prof. Jomo wanted to talk about. The universal health coverage is something, in reality, it means that no one is left behind. Even though you don't have money to pay, you're a lower income, you're a farmer and things like that, you will still have access to so-called essential health medicine and essential treatment. And this is happening in Malaysia. So if you look at the latest universal health coverage, our index is not the best, yes, but we are considered one of the higher income, higher index in the universal health coverage, if you compare this with other countries as well. So what does that mean? It means that no one is left behind. If you look at Malaysia public sectors, after this I'll come to some of the issues as well, but some of the positive points. Every 2 kilometers for any public servant and any public citizen, of course citizens of Malaysia, for every 2 kilometers you will have at least a health clinic or a clinic desa. So clinic desa is a smaller community clinic. This is mainly for antenatal care, mothers going into pregnancies and deliveries and so forth. So you will still have a health access for every 2 kilometers. Of course, there's area of certain barriers. Example, in East Malaysia, Sabah, Sarawak, and so forth, you have things which is access is even poorer and so on. So in this area, these 3 good points about our Ministry of Health and also the government's healthcare, in a way we are making a lot of strides. Example, Prof. Chan actually mentioned about the maternal mortality rate, which is already on the decline. It is so on the decline in that sense. We are not able to even lower it anymore, but we are able to improve the quality. Why? Because most of our maternal deaths do not happen in the government sector, most of them, unless of course they are foreigners or they come in, with problems and so forth. But with all the new barriers, new deglobalization and things that are happening, and all the wars which is happening, the imposition of tariff and so forth, we are also facing a lot of problems. So this is the maternal mortality rate, and this is up to 2011, but you see up to 20 and 24, you can see that it's always on the decline. Until one point it is almost plateau. Now, what are the current barriers with this? We've talked about the human resource. We don't have enough doctors, especially for the specialist doctors. Specialist doctors, when we train, Ministry of Health train, they go into the Ministry of Education and so forth. Once they come out, they will, most of them, not most of them, they will stay in the government, yes, but a lot of them, not majority, I would say about a third, will actually leave the government and they work into the private sectors. So with that, the government has come up with certain incentive things like, you have private healthcare even in the public hospital. So this is happening with Rakan KKM, with our private centers, even in, let's say, UKM, and so on, we have private centers. Why? Because we want to retain these specialists. Of course, it doesn't work all the time. There are issues as well on the private sectors in this public sector, but they are trying to retain these doctors as well. Now, increment of wages is not very easy, because if you increase the wages, you will get a lot of, not only, there's going to be a lot of aduan from other sectors, but we don't have enough to cover for that. But I do agree that Ministry of Health, in a way, it is chronically underfunded. Most of our budget percentage would be just around 5, less than 5, 4 point something and so, which is relatively low. And the second part of the barriers is that we have enough hospitals, but it is not running at what we want the top speed is. We have hospitals, but we don't have enough. So one of the ways that the government is trying to, mitigate this is using the IT system. So a lot of these hospitals now have so-called EMR, some sort of EMR, medical records, a specialized HIS, hospital information system, because we want to make this as efficient as possible. Now they are integrating a lot of AI as well in the procedures and a lot of investigation. And this is headed by specific sectors in the Ministry of Health. There are a lot of programs happening in the Ministry of Health, but there's not enough manpower, and of course, there's not enough budget. They are looking after malaria, they are looking after infectious disease, but also non-infectious disease, the NCDs, which is happening it's leaping up and up, and we don't have enough cardiologists, we don't have enough cardiology centers and so forth. So there's a lot of barriers as well, but there's a lot of strength that is happening. So this sort of initiative, forums and so forth, we need to tell the government, yes, I do agree on what's the problem and so forth, but they relatively know what's the issues already. So how to make sure that, let's say, the public can actually access private healthcare as well. Now, this is one of the ways that they are trying to do it, is through the MHIT, the Medical and Health Insurance and Takaful, which is sort of a micro insurance led by Bank Negara, where the amount of premiums that you pay would not be as high as a proper private health insurance. So this sort of micro insurance, where you might actually comes with a top up and later on, it's not there yet, but it's sort of micro insurance where the premium is not very high. And this is specifically targeted for the middle income and maybe for the lower income people. But at the moment, most of the experts will say that the lower income will have to be subsidized by the government. There's no way around it. So as much as possible, what happens in Singapore as well, of course, Singapore have their own private insurance, they have their own Medicare and so on. But the low income, or so-called the poorer communities, will still be subsidized by the government, where they can go and walk into the public clinics and so forth. As much as possible, we want that for Malaysia as well. And this is, I think a lot of the government sectors have actually noted on this. So where are we going for the middle income and also for the upper income? Upper income, there's no issues, because most of the upper income will have their own private health insurance. They are able to afford their own private, providers access and so forth. So what we are looking into more detail, I think the government is looking into more detail with the white health paper. I think Dr. David was there as well. On the white paper about 2 years back, is that to ensure that the middle and also lower income is not being jeopardized in healthcare. So this is something that we need to make sure, and of course I think the government knows very much about this, and to increase the efficiency. What we talk about as the value-based pricing or the value-based reimbursement, we are going to go into some sort of reimbursement system, but as a patient, let's say I'm a patient, I can actually access even the private provider, but it's covered by the government. Now the fund for that may come a bit later, either through social insurance or tax, but what's the intent is that if you're a patient, you might actually go to not only the public sector, but you can also access private sector at a small cost, or it's going to be again subsidized, or your insurance may actually pay for you if you're insured. So this is basically the general trajectory where the government as a whole might be heading. Of course, it's not there yet. Some of these are in transition. Ministry of Health, Datuk Sri Dr. Zul has mentioned about the MHIT a few times as well, and also the initiation for reform. But the areas of reforms we need to ensure, and this is where the forums like this must come, is to ensure that this is in line with our universal health coverage, so that in the end we don't actually transgress. Looking at that, one good example would be our catastrophic health expenditure, meaning that, you know, in some situation or in some community we don't have enough to pay for our healthcare. Tak cukup duit, we have to sell our cow, our land, blah blah blah. So that's catastrophic. So our percentage of CHE in general for Malaysia is still considered not to say good, it's manageable. It's not that low, but it's not that high. It's still manageable. But of course, if you look at certain diseases, example for NCDs and also cancer, the CHE that some of my students has done was up to almost 26 to 34%, meaning that the catastrophic for certain diseases needs to be focused on. And these are areas where we need to lead the government to show the government that, look, these are some of the areas that you need to actually highlight and focus on. So I think that will be my short summary, Prof. Chan, for healthcare.
Thank you. Thanks, Sharifah. Yeah, in fact, you've already begun to address a question which I was going to pose to you about, you know, if we have extra dollars again, what we could be spending that on. I'd like to bring Dr. Azraai into the discussion. Azraai, you spent 10 months as Special Functions Officer, Ministry of Economy. So let's think of this slogan, health begets wealth. Or to put it in terms of the title of the World Bank's World Development Report in 1992, Investing in Health, which was a landmark annual report of the World Bank. Now that title, whether you know the slogan "Health begets wealth" or "Investing in Health," Richard Horton, I don't know whether he's still editor of Lancet, but he pointed out there were two possible meanings to it. Investing in health could be understood in the sense of human capital, governments, or international agencies, spending money, on population in the health sector, presumably in the public sector, but not confined to it, to improve in the same way that you invest in education, to get an educated populace, trained with skills, which could, improve the productivity, labor productivity, and hence contribute to economic growth. Likewise, if you invest in the health of a human population, they're more healthy, they're more potentially more productive. So in that sense, but there's the other sense of investing in health from private sector. Investing in health, if you're a corporation, profit-seeking corporation, you would say, wow, the healthcare sector is a growth sector in the economy. This is where a potential source of substantial profits. And in fact, I mentioned earlier about Tan Sri Baka, pointing to the need to attract FDI, and hence maintaining low taxation and hence constrain the fiscal capacity of the state. What he did not mention, and connecting with what Jomo said, political decisions. Our even longer serving Prime Minister TDM, okay, Tun Dr. Mahathir, okay, we remember that he introduced policy of Malaysia Incorporated and privatization, okay, and I think it's arguable that part of the reason, okay, in addition to what Tan Sri mentioned, okay, was that there was a de facto political decision, okay, to not allow room for private healthcare sector to grow, okay. So that means that if you were to expand the private sector in line commensurate, okay, with Malaysian population health needs, okay, that would not allow as much space for the private sector to grow, okay. So, we can speculate as to whether that might have been a de facto policy, okay, of constraining even more rapid growth of the public sector to allow room, okay, for private healthcare sector to grow. Okay. Now, so coming back to your experience in the Ministry of Economy, okay, from your experience in providing health sector inputs into the 13th Malaysia Plan, what's your sense, okay, at least within the Ministry of Economy, if not within the MITI or the Ministry of Finance, okay, about the thinking among the higher level policymakers, okay, minister or the higher level technocrats, okay, about healthcare in the context of development, for instance, the 5-year plan. Okay. How do they see the balance between those two nuanced meanings, okay, of investing in health? Okay? Health begets wealth. Okay? Yeah. What's the thinking? Okay? Can you share with us, okay, your sense of it? Yeah.
Thanks, Prof. Khoon.
Yeah.
I gather that the crux of the question is on whether there should be more privatization of health. Now, if I get to that, when I came back to Malaysia and joined KKM, I was very much interested in improving health efficiency. But after about 10 years at hospital level, you find that you reach a brick wall and you just cannot go beyond. So when initially when I received the offer for the secondment to the Ministry of Economy, I thought, this is no place for me. I know nothing about economy, so don't talk to me about privatization, right? But I thought, okay, hang on, let's see what we can do there. So I go there and I find it's even harder to make changes way up there. So now going back to your question, it's really you have to see the Ministry of Economy is really more into the development. Basically, it's all about its DE. So this questions about privatization is really at the hands of Ministry of Finance, Bank Negara. Now, based on discussions, there were concerns, obviously, about how the public health is coping. I want to go to the question from the lady in the audience. I don't know, I can't remember your name, sorry. But about how DE works. Now, from what I understood being there, now we have an issue. Not only we have underfunding, we do not have enough development expenditure. So how does it work? Okay, in January every year, 150 public hospitals and 2,000 clinic Kesihatan will submit their list of requirements, repairs, assets, equipments, etc. This goes to their respective state health departments, who will filter the list according to which ones they think is prioritized. This then goes to Kementerian Kesihatan headquarters, where another filtration process goes through, and by April, it gets to the Ministry of Economy. This is for development expenditure, where a further process of filtration goes through, negotiations, before it's then finalized, and then the budget comes out in September. So you have 3 stages of filtration. So it's very clear why a lot of hospitals and clinics are disappointed at the end of the year. Now, when you say that 6 billion is allocated for development expenditure for the Ministry of Health, it's not 6 billion of new projects. Remember, about 4 to 5 billion has to be used for projects already in the pipeline or previously committed. So that leaves you about 1 billion plus.
So this is separate from maintenance, okay?
This
But
is separate from
phased,
maintenance. This is development. Okay.
Okay.
Then you have to deal with requests for additional funding for cost overruns from previous projects. That really cuts in to what you were hoping for the new projects. So in the time that I was there, I can say there was some work to try and deal with this, improving the planning and project execution to deal with cost overruns. Because if you think about it, if you have a majority of your projects having cost overruns, it's going to really impact your ability to roll out your new projects. Hence the delay. You see, why is this hospital was supposed to be completed in 2020, wherever it hasn't even started? One of the reasons is this issue about cost overruns. Now, I want to talk more about. We were talking about revenue. Now, Kementerian Kesihatan does collect revenue. But if you talk about revenue from, we had 2.5 million hospitalized admissions and 46 million outpatient visits in 2024. But the total amount of revenue collected was about roughly 500 million, 500 million. Which is just over 1% of the actual spending budget. So when I first realized this some years ago, I thought to myself, why bother to collect? We have people queuing up to pay the union, I say 1 ringgit, 5 ringgit. But why bother? Why not just skip the queues and just make it free at source? For some years, that was what I felt. But I feel differently now. I think that the concept of healthcare free at the point of source is a great idea. But for several reasons, I think that is wrong. And part of it is ownership of responsibility for health must be shared by everyone. And there is a bit of devaluing because in Malaysia, free is not valued. Okay, there is a value attached to it. So the cost of making everything free is a lack of respect or appreciation for the services. Now, if you were to say, some people say, let's just increase the charges to get more funding for the ministry. But even if you increase it to 10 ringgit, so a tenfold increase, at best, you're looking at an additional 500 million. It's not much. Right. It's not going to be, it's not really going to make a dent. But that's not the reason you would increase the price. For me, to increase is to nudge people into thinking more about the importance of looking after their health and the value of the health service. Now, we say that there are a lot of queues, but do you know that from my experience, if you're looking at, say, heart scans, waiting list may be up to 6 months. But in my experience, you had a default rate of 30 to 40%. 30 to 40% do not attend the appointments. But what's the issue is free. We just it's this concept of wastage and inefficiency. There is a lot of inefficiency, but you cannot really just blame the government or the ministry. Everyone has to share that responsibility. So I think in terms of this public-private debate, the private sector is responding to market forces partly, and if there was no demand, then they probably would not be increasing the number of hospitals. I did my calculation. there is in existence at the moment about 19,000 private hospital beds. If all the announced plans carry out, expansions, there's 23 new hospitals and about 10 hospitals that are expanding. You're looking at an increase of about 8,000 private hospital beds by 2030. So that is a huge increase of 40%. But the question really is what's driving this? We are living in a capitalist society. Commercial interests are dictating. This is like it or not, is the reality we're in now. So there is a question: should we be curbing this? But on one hand, do we have the right to stop doctors who wish to go to the private sector from going to the private sector? Is there what is in terms of privatization? If you can privatize other services, what's the issue with healthcare? I'm not supporting private healthcare, but it is in terms of the right. I find that it is difficult to curb. But what I think is more important here is looking at how we cope. Now, the fallout from an increase in a private sector, there are the pros and cons. They do provide additional capacity for our health service. So you are increasing the number of beds. You're complementing the government healthcare program. The downside is in terms of shortage of staff. And this is a global phenomenon. It's not, we have a global shortage of healthcare workers. We have to deal with the fact that there is not going to be enough doctors and nurses, be it in public or in private, in this country or anywhere in the world.
Especially if you're after medical tourism as well.
Yeah, you are not going to have enough doctors and nurses. Okay. That said, I think Malaysia has done very well because from 2005 to 2025, over a 20-year period, we reduced the ratio of doctor to population from 1 to 1,300 to 1 to 400. This occurred by rapidly increasing the number of medical graduates coming into the workforce. However, we were not able to match it with increasing the number of specialists to manage and lead the workforce. So this is the predicament we're at. We had to rapidly expand our workforce. We do not have enough senior expertise. In the country as a whole, there is one specialist to about 5 to 6 junior doctor, compared to developed countries where the ratio is more to 1 to 1.5, and in Singapore it's 40% of specialists.
They're more concentrated in the private sector, especially the senior.
The other issue is that whether they are contributing to the training. So one loss we have is that once the specialists leave to the private sector, they are divorced from the training and development of the juniors. I think that in terms of public-private partnership, it should not be a one-way. At the moment, public-private partnership means outsourcing services from the public sector to the private sector. I think it should work both ways. We should have private sector healthcare workers coming into the public sector. There needs to be more fluidity. Where perhaps policy can come in is to facilitate this, to make it something that people will want to do. I think people want to do it, it's just that there isn't a mechanism to achieve this. We have to do this because this is, to me, very important, and I speak this from a personal point of view. I don't represent any agency or government body at the moment, but I think this is something that I think we should push for. And the training is going to suffer. To me, that's the most important, because specialists will come and go, but we need to ensure that the next generation of specialists will come. We have to come from somewhere, and if we do not have the training manpower, so I think in that sense, I don't think you can stop the private healthcare expansion, because there is a demand from the economy, from people with the ability to pay, but we need to look at how we can integrate it better, how we can cope, how we can regulate better. So I think we are beyond the point where we can stop the private healthcare expansion.
Okay, that's right. I know you may not feel comfortable speaking from the KKM perspective now. Okay, now that you're not within KKM. Okay, but nonetheless, the Minister, okay, Dr. Zul, okay, has reminded us, okay, on a number of occasions that as Health Minister, okay, he's not just responsible for KKM, okay, but also in his regulatory capacity, okay, sometimes not him, sometimes the DG, okay, regulating the health system in total, okay, both the public and the private, okay, so that it functions in the overall interest, okay, of the nation as a whole, citizens, and also the business and corporate sector, okay. I think we in Malaysia have a very unusual situation, okay, in which the state is juggling multiple hats, okay. It's a funder and provider of public sector healthcare, it's a regulator, and it's also preeminent investor, okay. Preeminent investor in commercial healthcare, okay. So when Dr. Zul says that he has to wear multiple hats, okay, as health minister, in the public sector, okay, as regulator, okay. So what are your thoughts, okay, on how this, what I think of is a rather conflicted state, okay, where it's juggling this multiple hats, okay, in the healthcare sector, okay.
I think if you look at the white paper, the direction is clear that the health ministry, the aim is for devolution, for the Ministry of Health to take more of a regulator role. But reform is difficult. If to reform yourself is difficult, because the Ministry of Health will have to basically divorce some of its functions. So I think
as a provider, you mean?
I mean, no, yeah, as doing everything. So it's basically shrinking your powers. So it's not easy for anyone to give up their powers. So I think in terms of reform, there needs. I mean, if you look at the white paper, they talk about setting up a body or a council for this purpose. So I think if you really wanted to reform KKM, the reform must come from both within and from outside. It is difficult for anyone, to carry it out a full reform internally. So it has to be done, but I think it's going to take a bit of time.
Okay, I think we have to wrap it up in 10 minutes, Can? Okay, because we'll take a short break after that, maybe 5 minutes, and then resume with the Q&A, which Manvir will moderate.
How do I go forward? See, this one. Young name. It's gone off? Okay, can I? All right. Okay, I just want to focus on a few questions. I mean, this is what we've been talking about, how the federal revenue as a percentage of GDP is going down. That's the crux of the issue, right? So because, if you ask the government, obviously they cannot run a bigger deficit, and they get a bigger loan, then they got to pay back the yearly payments. The debt servicing is already 56 billion, more than the health budget. So memang what they're talking about is, we keep the same framework, you cannot go and demand for more. Difficult. And that's why Dr. Zul is going for KKM, let me earn money separately and all that. So it's logical. What he's doing is logical. But I think if you want to look at how to improve things, we got to also look in the long term. For next year's budget, of course, we can't increase. But the longer term, how should we think about why? I think this issue of why is our revenue as percentage of GDP coming down? And can anything be done about that? That should also be what the government should think about if you're thinking about the longer term, right? I think it's this is discussing health, but the overall economy is important. So I think we've also got to talk about these kinds of things. And if you look at it, since the 80s, the rules of international trade and commerce have been altered to favor the largest corporations. Okay? This is a fact, right? So is this, are these political choices? Is this, kind of given to us from the Almighty? Where is it coming from? And can it be reversed? That's more important. So I think we need to look deeply into this. What has changed? One is why has it changed? Other is how is it helping the billionaires get richer? And how is it helping billionaires not pay taxes to the government? What are the factors? And if you look at things like this, all our free trade agreements, we talk of national treatment. National treatment means once you have the free trade agreement with that country, their corporations should be able to invest in any field that you are opening to your locals. Otherwise, they can sue you. Promotion of free trade at all costs. Free trade is like the most important thing. Doesn't matter if free trade affects your food security. Doesn't matter if imports of cheap vegetables from Thailand affect our local farmers. Doesn't matter. Free trade is important. These are things. Concept of export-led growth and reliance on FDI. Intellectual property rights, which allows big companies to fence up the commons, to take over knowledge. Even if a smaller company develops a breakthrough, they normally have to sell it to the bigger company because they can't market it. They can't scale it up. They don't have the network. So all knowledge goes to the largest companies and it's not shared with the working class, not shared with the people. ISDS, which allows companies to sue our government in an international tribunal, can bypass our whole. These are the things that we have created that enables the rich to become rich, the billionaires to become, and to avoid paying taxes. And of course, weak laws regarding corporate financing of politicians, where you find in many countries, the politicians are in the pockets of the billionaires. These are the things that actually have led to that graph of our revenue dropping. So the question you got to think about, if you're serious about getting more revenue to help our population, you got to look at these things and see what can we do about this. Maybe it can't be done overnight. Can't be done for the next budget. But a 15-year, 20-year thing, we got to think about what is the political actions we need to take. What are the political forces we got to develop? What is the ideology, the thinking we got to develop to push back? Oswald keeps on coming and saying, things like this. Billionaire, here he says, look at that. Billionaire wealth has increased by 81% since 2020, while nearly half the world's population live in poverty. Billionaires are 4,000 times more likely to hold political office than ordinary people. And the 2.5 trillion increase in billionaires' wealth is enough to eradicate extreme poverty. So we keep on seeing these kinds of things. It's true. Because of the structural changes to our international economy. So we got to think about that as well. How do we change that? And it's not really, you see, like here in Malaysia, we just talked about how our corporate tax in the whole ASEAN region
has come down, you know. But you look at ASEAN, we have a population of 680 million. That's double the US population, you know. But as a market, it's not important, not an important market to us because everyone earns so low. We're dependent on the US market. When Trump comes and says, I'm going to put tariff on you, we go dance with him and all that because we're scared. And we are scared. Any government would be scared to be hit with a higher tariff than Thailand gets. Then we lose to Thailand, we lose to Vietnam. So that's because we don't have the market. You see, the things we can do, but these are not things that can be done immediately. For example, ASEAN, we have a free trade agreement. We can expand that to say that we should increase corporate tax rates to 30% in all our ASEAN countries over the next 10 years. This can be negotiated because that would mean that all our ASEAN countries don't have to borrow so much money to meet healthcare needs or give old age pension or to look into environmental issues. All our ASEAN countries need the money. But things we are fighting with each other. It's a race to the bottom. Can we stop the race to the bottom? Can we have a discussion? Can we increase minimum wages by 10%? These are not easy to do. But if you do increase minimum wage, it means that your ASEAN market becomes deeper. That we can sell to Indonesia, Indonesian businessmen can sell to us. We're not so dependent on Europe, not so dependent on America. These are things that we got to think about, you see. So this is bigger than just health, you know. To improve the healthcare budget, we have to think about these kinds of things. Our GDP is growing, but the tragedy is we can't share it with our people. We can't raise wages. We raise wages, the investor will not come here, he'll go somewhere else. We can't give it to them in terms of better healthcare, in terms of social wage, because our budget can't be increased. So we're getting richer, GDP is increasing, but we can't share it with our people. So something is wrong, right? So we've got to think outside the health budget box and look at where are we going, for these things. Yeah, you've got to bring issues like, for example, like tariffless trade is pushed by World Bank and IMF, WTO as the most important thing. No tariffs, no. So these kinds of, but then how about food security? How about employment? So I think these issues, to solve these kinds of issues, we've got to actually question the kind of teaching that World Bank and IMF and WTO have been pushing down our throats, And we go back to what Tun Razak was talking about. Go back to what Bandung in 1955, what Sukarno and Nasser, and what were they talking about? Independent, that the third world, as we become, now is so dependent on the global chains. It's neocolonialism. So I think it's political, really. This issue actually is political. Where do you want to go as a nation? How do you want to share? And the role of government is to take money from the richest people and improve social security and build solidarity, So the poor people are not left high and dry. It's a very important role the government has to play. So I think you cannot keep health budget just within just health, Got to look at the whole thing of where do we stand, where do we want to go as a nation, and to build the ideology, the discussion, things like this, that we need to be berdikari, that we need to be independent. There's got to be, delinking and all that. So we cannot listen to these guys, okay? These guys, whatever they say, must take it with a pinch of salt, test it very clearly, because what they've done in the last 30 years is make us dependent on the West. And we cannot go. Technology, we are stuck. Food security, we are stuck. We cannot break free. And Africa, look at Africa, for example. They were exporting food to Europe during the colonial period. Now they're all dependent on food, So these guys are toxic, actually. You got to be very careful with them, okay? You got to think of people like this, Samir Amin, talking of delinking. Other guy is Clive Thomas, he's a professor from Guyana, talking about how do you develop in the third world. Guy down there is Fadel Kabub, Africa, what there. There are people thinking. you know. So I think we got to start thinking, we got to get a little bit more intelligent, I guess, and look at the real issues and stop looking up to the people from Harvard and World Bank. Really very important. Thank you. I'll stop here.
Thank you, Kumar. That's exactly what we needed to hear. Okay, in answer to that question, why are government revenues falling as a percentage of GDP? I think that was a very well elaborated answer. Okay, but I think your logic, okay, is so compelling that even IMF agrees with you. At least one senior officer, the deputy managing director, okay, Japanese guy Masahiro Furukawa, I think. Yeah, just about 5 or 7 years ago, okay, he was addressing a regional gathering, okay, I think of finance ministers of ASEAN in Jakarta, okay, and he said pretty much that, okay, that ASEAN member states should coordinate among themselves, okay, to adopt a common corporate taxation policy, okay, and not engage in this spiral downwards, race to the bottom, okay. So very much in line with the logic, okay, that you were putting forth. Even IMF is coming on board, okay. Okay, thanks to the panel, okay. I think this has been a very rich discussion, okay. Fantastic, okay. I more than exceeded our aspirations, okay. Okay, we'll take a short break now for 5 minutes, okay, and reconvene, and then Manvir, okay, will moderate, okay, question and answer session, okay, to get the audience, okay, more involved in this. Thank you very much. I should mention that I think I've mentioned it already. This is being live streamed. So for 30 days, it will remain on the live stream platforms, Facebook platforms, okay, of both CITRA UKM as well as the UKM Medical Faculty. So you can always refer back to the raw footage. Thanks.
Just. Okay, good morning once again. If you could just find your seats, we'll restart this moderation part of it. Okay, good morning once again. My name is Manvir Victor from Vital Signs Asia, part of the partners here for this event. So what we're going to do next is we've got the moderation, and we've got quite a bit of questions from our people who are following us on Facebook right now. It's happening on Facebook Live. So we're going to open up to questions and comments from every one of you who are here. But because the cameras are over there, I'm going to ask you to introduce yourself as well. The people on Facebook know who you are. And please speak into this mic so that they can hear it as well. I'm going to start off with a question first for the panelists. This one comes from our Facebook. So I'm going to start with Prof. Jomo first. This is a little bit of a softball question, I guess. What's your take on Malaysia becoming an aging country in 2030? So asks Suhaimi Saidin, who asked, if you could pass the mic to Prof. Jomo. Nothing personal, but he asked that question. Go ahead.
Yeah, well, I have to take it personally. But
okay.
I wish Khoon was here because he was my senior in school.
Oh, okay. He's over there. He's hiding in the corner.
Okay. Yeah. No. I think we have a very interesting and challenging problem. My former colleague Nazia basically pointed out that although Malaysians are living longer, we're not living as long as we potentially could given the levels of income in this country. Number one. Number two, basically we are also not living well.
Okay.
There are different measures of how you spend your, and the the last few years, the last decade or so of life is pretty bad for most Malaysians, and this is part of the challenge which we face. Now, part of the problem, of course, is NCDs, non-communicable diseases, and the growth of NCDs is very troubling. And part of the reason, of course, is that we have not done enough preventive health as far as NCDs was concerned. So one of the challenges I had years ago when I was working with the Food and Agriculture Organization, we organized the second international conference on nutrition.
Okay.
And what we found is that very simple lifestyle issues could make a huge difference. So if we had, for example, much more deterrence to bad lifestyles.
Okay.
For example, the amount of sugar we consume in this country is a major problem.
Yeah.
And likewise with a variety of other things. Earlier we were speaking to somebody who he basically reminded me that the problem I face in my workplace as well as in my residence, where I live in it's impossible to use the stairs. I'm almost obliged to use the lifts. This is completely waste of energy, but it also basically induces a very poor lifestyle on my part, where I hardly climb any stairs and so on and so forth. So there are a whole range of things like that, which when I was growing up, ethnic Chinese drinking tea would drink tea without sugar. Okay, yeah. The idea of drinking tea. Today you have tea. You have so-called tea with a lot of syrup, okay? And a bubble tea. I didn't know whether I would be. I might be sued. I've already been sued a few times in my life, so it's not exactly. So I didn't. But I think we have some serious problems. So I think a lot could be done in terms of extent. And the males in this country, the male life expectancy is 5 years lower than the female life expectancy in Malaysia. Now, this is generally the case the world over, but not by such a big differential. And so there are many things like this. But I think and part of this, I think, is due to the neglect of preventive health. There are also a lot of women's conditions, for example, which can be can be easily addressed by by testing and so on and so forth. So I think there's a great deal which needs to be done. But if I may, there was a question which came up earlier, which I think was not, where I remember the last time I spoke on these health financing issues, I was with a conservative man who used to advise the Conservative Party of the UK.
Okay.
Professor Jeffrey Williams, okay, who lives in this country. And Jeffrey Williams says he's very conservative, but he says the first lesson he learned when he was studying economics, the first lesson he learned was that the laws of conventional economics do not apply to health. So this is part of the reason why, for example, the whole field of health economics is really very much an American phenomenon rather than British phenomenon.
Okay.
Okay. You go to the London School of Health, for example, you're not subjected to the kind of, and the health economics which is taught is very problematic. And in fact, the most interesting work in health economics are precisely by people who recognize that health is not subjected to the laws of the usual what people assume to be the way economies work and how we are supposed to be analyzing economics. This, I think, is very, very crucial because as a consequence of this, we misdiagnose. Can you imagine
Sure.
For medical people to misdiagnose a problem. So when you get your diagnosis wrong, how are you going to get things right? Okay. So I think it is very important that we do much more, and a lot of these things it's not just a question of money, but I think the emphasis today on underspending as far as health is concerned in this country is a very serious problem, and it's going to compromise the ability of Malaysians generally to live well into their old age.
Great. A good point you brought up, because you were talking about a lot of other areas outside of health. These are social determinants of health that, at the end of the day, impact health. I think, Prof. Chan, you've got a question from over there.
Sorry, can I just add on the aging society?
Sure.
Sorry, Prof. Chan, just 1 minute. Is that who actually takes care of them? That's another issue. Remember, they are aging. It can be our parents, it can be our community, and so on. They are aging. Who will take care of them? Some communities, they just put them in the old age homes or whatever. But the second perspective is that they will take care of themselves at home, and sometimes they are so-called non-formal caretakers. When they are non-formal caretakers, they sometimes have to stop working and things like that. So who compensate for them? When we talk about economics, we want everybody to work, because in the end, by right, we want everybody to pay taxes to the government. But most of these people, sometimes the usual burden will be falling on the ladies of course so the children and so on. So the non-formal caretakers, who would pay for them? So there's some work being promoted trying to actually pay for these compensations and so on. Social workers is very expensive. It's very difficult to get. In certain countries only that they actually provide free social workers for elderlies and so on. Most of the countries do not. And I think Malaysia have not actually prepared for this, especially if you don't have money. So who is going to take care of this elderly? That's another issue that I don't think that we have we have not solved the problem yet.
Okay, good. Prof. Chan, question?
Okay. There's a question from Ong Yi Wei through the live stream. It's addressed to Sharifah. Prof. Sharifah, according to Malaysia's National Health Accounts data, the public-private financing split has narrowed to roughly 51 to 48, 51 as opposed to 48%, with household out-of-pocket payments accounting for more than 1/3 of total health expenditures. If that trajectory continues, what are the implications for the government's ability to attract and retain skilled health workers in the public sector? And is the current remuneration framework sustainable?
Definitely, the current remuneration is not sustainable for the government. So it's not sustainable. But most of the OE, operating expenditure, is going into emoluments at the moment.
Okay.
We are paying so-called the specialists at the government sectors. We are paying a lot to the specialists, but again, this is not enough, because let's say you earn 30,000 per month in the government sector, senior professors or senior clinicians, but you can get 60 in the private sector. So why should I stay? That sort of thing. So remuneration is definitely not enough. This is one why they have the public-private so-called partnership, and you have the private centers in the teaching hospitals, and now we have Rakan KKM, in the public hospitals and so forth, so-called to retain these specialists so that they can do so-called private work or private wing work in the public sector and gain some money. So in a way, that will actually cause some problems as well. Not going into detail, but it causes some problem because not all patients can go there. If you're a low-income earners, how can you go and pay for the private service in the public sector? So it creates a bit of, a dichotomous there. So the second part is that the out of pocket, yes, it is increasing at the moment, and we are very scared of that actually, but it's very difficult to curtail. The issue is that we have the public but also the private sector. So when we talk about the public and private, most of the inpatient would actually go for the public. So it's almost 60-40. But if you go for outpatient care, GPs and things like that, most of the patients would actually go for the private. Ease of time, more satisfaction and things like that. For the private, no, it's the other way around. Even though that the private hospital have a lot of specialists, not many people can actually go there unless you're like insured, if your employer pays for you and things like that. So the out-of-pocket is increasing, and we need to, you're right, this is how, why the reform has been started, because we want to reduce out-of-pocket as well, and we want to ensure that even though you are not able to pay, you are able to seek healthcare. So that goes into so-called the reform, thinking about the insurance and so forth, where you have money or you don't have money, but if you're insured, you can actually go and access healthcare in the private sector.
Right.
This has happened in Indonesia. We did some consultancy back there with Prof Said and so on, the INA CBG and so on. So they have a lot more coverage now for the poor people. Of course, they have a medical card lah, and it depends on your medical coverage, your benefit packages and so on. But at least you get to see a medical doctor at some form, even in the private sector, if you have your medical card and so on.
Good points. I just want to connect what you said to what Dr. Azraai was talking about earlier about the pull factor for some of the people in public to go to private, right? Because of the salaries that they're about to earn. But also alluding to the point that you made about not enough specialists. We have enough doctors, not enough specialists. So that looks like maybe there's a flaw in the system, there's a gap somewhere in the system. So is that a push factor? Because we're talking about pull factor, is that also a push factor for people to look and say, should I still remain in government because I'm never going to get to do a specialization, earn more money, do all those things? So is there a push factor as well to be considered here?
People leave the government service for many reasons. It's not just for higher salary. Sometimes it's more to do with personal reasons. There are also issues with relates to, as you become a specialist, especially if there are fewer specialists, you have to take on more administrative and management roles. You have to look after quite a number of junior doctors. So some actually feel they want to focus just on clinical work. So that might be another reason why they leave. So there are many reasons. There's been studies look into that. Certainly, if there are less remaining, there'll be greater workload to those who remain. So that again is a reason why that can create stress. Now, the reason why many people remain is because they have a pension waiting for them. So with the upcoming newer specialists who are no longer in the pension scheme on the EPF, there is perhaps they don't have that incentive to remain. So incentive to remain might be due to the love of your job, because in the government sector, you get to see the cases you were trained for. You have a high concentration of complex cases. So from a point of view of your professional and your career, you might find it more rewarding. You get to treat lots of cases, whereas in private sector, you may not see such cases. So there's always this constant debate. Should I leave or should I stay? And at the end of the day, sometimes what tips the balance is having some incentive, some policy, something to show that they are being appreciated. You may not need to give high salary of 60,000. A lot of my colleagues are not after such huge salaries, and just some appreciation. It perhaps is what they need.
Prof. Jomo, I'm just going to jump to you because earlier when you're talking, you said about your friend in the UK. We should not think of healthcare in the conventional sense of economies, right? That's what you said just now. And when he's saying that, Dr. Azraai was talking just now about the push-pull factor, different reasonings. Should we start to think of healthcare professionals in a different sphere? That, they have to have more benefits or more incentives to stay within the government system because health is a human right. Health is a human right. We can all agree on that, right? So should we start thinking of a person, a doctor or nurse who are working in the government as different from someone who's working in JKR or any of the other departments, other ministries? Should we start thinking of that? Non-conventional. It's coming back to what you were saying just now. Shouldn't be conventional.
Is this better? Yeah. Okay. I think we have a situation where I think Jeffrey Williams lives in this country. Okay, so he's not living somewhere else, and he was referring to the way we think about the economics of health. That we shouldn't be thinking about economics of health as an extension of economics just applied to any other sector. Health has got certain characteristics which compel us, require us to think otherwise about health. Now, what it basically means that we think about the system and the incentives and disincentives in health rather differently. He was not referring to thinking about health personnel in particular, but obviously I think it is important for us to recognize this. I earlier referred to the fact that I visited UKM's medical faculty 45 years ago, and at that time Nasir had just completed a study on the motivation of medical students. And at the beginning of the medical students' career, they were tremendously, very highly motivated, quite selfless, and so on and so forth. By the end of their, by the final year, their motivations had changed. Okay, now this probably exacerbates, worsens many of the other problems of disincentives and incentives, which our fellow panelists have been talking about. I think it is generally true of most people that not everybody thinks that everybody's incentives are what economists assume their incentives to be. That not everybody lives by making money alone. And that's why, for example, during the 1980s, basically the view about privatization initially, and in fact it has persisted, was that can make money or not, and that became the criteria as to whether you privatize some part of the health sector. Okay, so you could make money from, for example, getting rid of toxic waste. You could make money from all these kinds of things, and then you basically cut off. You break up the health the health system in these ways by the criteria of whether you can make money or not, privatize those things, or and then the whole system becomes quite incoherent, and you have this kind of incoherence with a lot of pockets and so on and so forth, which makes it very unmanageable. So I think it's very important for us to think and to think about things rather holistically, and this is, I think, crucial for us to think in terms of thinking about health reform and so on and so forth. When Bevan proposed the National Health Service in the 40s, there was resistance from the British Medical Association. British Medical Association voted overwhelmingly against it. By the time Mrs. Thatcher tried to dismantle it during the 1980s, the situation had switched. The British Medical Association basically sought to defend it. Of course, they basically undermined the National Health Service by other means, not by completely dismantling it, by defunding it and so on and so forth, and changing the incentives and so on and so forth. So the questions we have been hearing about, raised by participants, are important questions. But I think we have to recognize that people are motivated by many different things, and we should be enabling people to stay in the public sector, of serving of serving the common good and so on and so forth. And this I think is quite crucial. Earlier, for example, a comment was made about people not showing up for appointments. I don't think the question was simply a question of whether or not they have money. I have a friend who unfortunately passed away, who was shunted from one appointment to another. No charge, but one appointment to another. And the final thing was, the there is only one specialist left in government service in Putrajaya. So you have to go to Putrajaya. In this case, I think it was diabetes or something like that. Apparently, Putrajaya has the highest incidence of diabetes anywhere in the country. And so the correct me if I'm wrong, Dr. Azraai, but obesity too, yeah. No, I think they can be highest on a number of things. One doesn't exclude the other, right? But it might speak to the nature of the lifestyles. But whatever the case might be, the point is that, so you have this friend, a friend coming from Kelantan, coming to KL, trying to manage the way, you basically end up having no choice but to try to grab. If you don't have money for a grab all the way to Putrajaya or some other distant hospital, these are OPEX, out of pocket expenses, which are very important. Okay, so I think we have to assume that people who, there are very few people who who take the time off to want to see a doctor, just for the sake of making an appointment which they feel they can break. I think there are often very complex and other motivations at work, and we need to think about those things. So I think it's important for us to appreciate the complexity of the health system and not be persuaded about that, that everything works the way it is assumed people work. Yeah. I mean, you take, for example, insurance, right? One of the things Adam Wagstaff, Kumar, this man used to work for the World Bank, but he actually did some very good work, and he actually showed that insurance systems raise the cost of health by an average of about 4%. Okay? And private health insurance is even worse. Okay? And that's why you have 18% of GDP goes to health in the US. But you're not even anywhere in the top 20 in terms of health outcomes in the US. Okay? So these are things which compel us to rethink, what are the motivations, what are the outcomes, and so on and so forth. So whoever raised that question, I think is onto a very important thing. But I think the issues are actually quite complex, and we really need to think about ways in which we can get better outcomes through a combination of the appreciation of the various forces at work. Thanks.
Thank you. I'm going to open up. Anyone who's got questions, just put up your hand. I'll bring you the mic. Anybody? Go. Tasha, go.
Hi, hello everyone. I'm Natasha Sharif. I'm from Boleh Space. I think of myself as a patient advocate. So I just want to point one thing back to what Dr. Azraai talked about in the previous session. So he says we need to get people to change their behavior to be more health centric. But I think we need to look at it in a more broader sense, which is based on the social determinants of health. So there are other things that are systemic that are out of the control of us as individuals. So that thing needs to be really studied and then shared with the other ministries that are in the government. So this shouldn't be on the shoulder of KKM only. So other people needs to take into account, like food security, the wage needs to be dispersed fairly, things like that. That's one thing. And then there's another also. Just want to make sure that we center healthcare as a public good. So there's a quote by Philip Alstom. He is the UN Special Rapporteur on Extreme Poverty and Human Rights. So he criticized the privatization of public good because it shouldn't be done at the expense of throwing rights protection out of the window. And then proponents of that present privatization as a tax solution for managing resources and fiscal deficits. We've been hearing a lot about PPP, but have we seen enough evidence that say PPP is actually working as per intended? So essentially, those are my questions and comments. Thank you.
Can I answer on the social determinants for a while?
Go ahead, go ahead, Prof.
Natasha, very good comments, which is true. Because in general, a lot of the access to healthcare is sometimes available, but there are many reasons which hinder a patient to come. I do agree with that. Even though the clinic might be in front of you, but for certain reason, it can be community, it can be familial and things like that. Example, the husband do not allow the woman to go on her own and things like that, you know, someone to take care of the children, blah, 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 and so forth. So they don't attend the clinic. So access is one. Another thing is the cost, and sometimes the cost is not so high, but sometimes the patient do not come forward. Example, our public healthcare services, the cost to pay is actually very low, not that high, RM1, RM5 and things like that, but sometimes the patient do not come as well, or do not follow up, or do not comply. So the encouragement for self-care is true, but you are right. And some conditions, like what has been mentioned, when access is there, but certain access, especially for a specialist or certain procedures, which is not available, and the patient has to be referred for many areas and things like that, which actually deter the patient, and until the patient sometimes go up of the system, and then they go into traditional, and which doesn't work, and especially for cancer and things like that, and the patient just in the end is a fatal case. So things like that. So not only access must be available, but how do you promote? I think among the community, that's another factor, and that's very difficult, because the level of the way that we come out as in general is you must take this, you must do that, like we are the Napoleon of the country. In reality, by right, we should be able to better communicate, better advice in a better condition. The problem is that once the burden, especially even in the private, I think GPs, sometimes it's too much, and this is where the stress to the doctors become. When we were trained, we were told that you must only allow 5 minutes per patient, less than that. You have more than 5 minutes, you cannot go back at 5. You have to go back at 6 on your own, something like that. So we were told not to actually, because of like you have to finish like 200 patients per morning or something like that. So that becomes a stress to the providers as well. So, and I do agree that it's not only healthcare, it focuses a lot on education as well. For me personally, we look at a lot of data. You improve the income of that family, in a way, everything will improve in a way. And of course, not short term, but long term. You improve the income access to the family, household income especially, who is the leader of that family. Household income increase, in the long run, the children will have better education, better lifestyle, better access to clean water, blah, 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 toilet, and so forth and so forth. So that's in general. So when we talk to the newspapers or media, we always say this, that, but in the end, it should be the improvement of the whole community, right? So the second question, I forgot already. So what was the second? Oh yeah, the PPP. I think during COVID, we had a good example where during COVID, some of our patients from the public sector was actually, provided or sent to the private sector. We use their wards and things like that, but in the end, the government pay for it lah. That's another thing. Another part is that how sometimes the congestion in the public sector, like we don't have example MRI and things like that, so we sort of subcon to the private sector, and it is still paid by the public sector. So we still pay for them. So other than that, I think the PERKA B40, PERKA B40 was actually it was still subsidized by the government. The patients can actually access private GPs, general practitioners, for their NCD treatment and things like that. So they don't have to go to the clinic Satan, queue for many hours and things like that. So easy access to the GPs. But still, the funder, very important, is the funder. Who pays for that? So the funder was actually still the government. So in that sense, we are able to utilize the private so-called entities, GPs and so forth, or labs. But the payment is still by the government in that sense lah. So that's I think not the only I think some of the examples that probably I can think of at this point.
Prof. Shan, you got a question from somebody?
Hello. Yeah, actually two again coming through the live stream, which are related. So I'll read it out. The first one is from Ahmad Hafiz Muhammad. Soalan, kerajaan ada perkenalkan inisiatif seperti program kesihatan madani, di mana public boleh mendapatkan khidmat kesihatan di private sector. pendapat panelists can this help our system? And the second related question, is there a possibility of legislating requiring private doctors to spend 2 or 3 half-day sessions in government hospitals? This comes back to the government juggling multiple hats, okay?
Yeah.
Provider, regulator, and investor, okay?
Sure.
To the extent that the government is a major investor through Khazanah and through IPF and other statutory bodies, okay, in commercial healthcare, okay, can the government actually use its owner role, okay, where is ownership hat, okay, in regard to this private healthcare corporations, okay, to require them to perform some kind of national service, okay? For instance, okay, we could imagine a situation in which, as a requirement for licensing of private hospitals, okay, the private hospitals, okay, private in the sense of modus operandi, okay, private hospitals will require to set aside a certain portion of their beds, okay, to absorb, to take in decanted patients, overflow patients from KKM, okay, at discounted practitioner rates, much in a way that real estate developers, okay, are required to develop a certain portion of low-cost housing, okay, in order for the approval, okay, of the housing scheme in total. Yeah.
Good thought process. Anyone want to jump in first, Dr. Azraai, and then Dr. Jeyakumar? Yeah.
I think the first question already covered by Professor.
Okay.
Just now. In terms of, I can think of one example to quote is that in South Korea, their constitution states that all private hospitals has to be not-for-profit entities. In fact, they had to make an exemption because there was one hospital built for medical tourism, so they gave exemption for that hospital. But it's interesting, but that's the route that they took. So actually, if that's what the majority feels, then then you would have to make this, in terms of a law. I think it is. I mean, I don't think you may have to go down the route of actually having to make laws in Parliament. There can be a consultative process. I believe that private hospitals, despite being corporate entities, they are in the health business. So I mean, in some situations you can undergo a consultative process. I think that would perhaps be the better route, rather than going straight into legislative process. Legislative process only when consultative processes fail. And I'm sure there are a lot actually of private physicians who are very active in humanitarian work and contributing back to society in many ways. So I think what can be done is to facilitate that, making it easier, and perhaps having some consultative process would be useful.
Okey, saya nak respon kepada saudara Ahmad Hafiz berkaitan dengan klinik Madani. Itu saya rasa, jika saya faham, sedang dibuat di hospital-hospital yang terlalu sesak lah, di mana mereka diberi kupon untuk pergi ke hospital, kepada GP yang swasta untuk clear the crowd lah. Saya rasa is even more important jika kita boleh memperluaskan skim ini untuk hantar pesakit dengan kencing manis, darah tinggi allocate mereka kepada GP, klinik-klinik swasta yang menjadikan dia punya personal doctor lah, macam NHS system di UK. So ini akan bagi lebih, ini akan offload kerajaan dan juga akan bagi personalized care untuk pesakit ini, di mana semua ubat dia, semua testing dia ditanggung oleh kerajaan. Dia tak bayar apa. Macam kerajaan saja dia mari ke sini, dan mungkin dia boleh dapat untuk galak mereka, patient yang buat macam ini, jika dirujuk balik kepada pakar di hospital besar, dia dapat green lane lah, lebih cepat. So kita encourage dia pun. So mungkin that scheme Madani boleh memperluaskan.
Okay, we've got very few minutes left. Any other questions? Yeah, Nadia, come.
Sorry, I had a comment and a question talking about private healthcare, which is obviously close to my heart. I think this issue about, using regulation and licensing is creating sort of like a perverse sort of gatekeeping culture that's very pervasive in our healthcare sector right now. Because, for example, high barriers to entry to licensing means that it's driving scarcity. There are more investors coming in to acquire because it's so hard to set up on its own. And then valuations get very high. And then when these get bought over, then the hospitals have to deliver a certain margin in order to pay back investors. There's gatekeeping in registration of specialists. There are some subcommittees that only meet once a year. And if you miss that, you have to wait another year. So if you say you don't have enough specialists, but you're sort of creating a self-inflicting problem by gatekeeping the number of specialists, then is giving you more money going to solve the problem? Teleconsultation is a technology that is so old, but it's still not recognized. It's not being used. And we know that it can lower costs. We can provide access. So are we willing to sacrifice quality? Because many of these choke points were created in the name of maintaining a certain level of quality. Are we willing to sacrifice that? I guess it's an ethical issue. How much health is a human right, and are we willing to sacrifice that quality in order to provide wider access? But actually, the question that I actually had was, is KPIs actually effective in driving outcomes for this? Because in my experience with the NHS, for example, they set a target where they wanted a certain percentage of early detection of cancer. They made it a very clear policy, and then they went back and they looked at social determinants of health, why people are not showing up for screening appointments, transportation issues, access issues, prevalence of gig economy, and the fact that people can't afford to take a day off because that means they're not earning an income on that day. And then they came up with different programs in terms of having mobile screening, having transporters to transport patients, because they were being guided by the one single point of, we want to increase early detection of cancers because that would lead to better outcomes. So, but are we having a similar approach here in our health sector of having these sort of very clear guiding lights to drive policy and decisions?
Anybody?
Some of the KPI, there's a lot of KPI, right? If you're looking at finance KPI, you're looking at clinical KPI, surgical KPI, and so on. We have peri-operative mortality KPIs. We have KPIs on procedures being done by clinicians and so forth. What we know, patient safety goals and so on, which is done every year, data is being collected. The issue is that whether it has been audited and any action has been taken to remedial the problems. From what I understand, some of the quality initiative in the hospital, public hospitals, private may have their own, but usually they follow the central one. In the public hospital, they do have all these central state government-owned KPI which have to be adhered to the teeth. But of course, when you do that, you have to actually monitor it, right? Still looking at the trend, and there are committees already for that. There are very specific, very strict committees for that. Infectious disease, HIV, maternal mortality, even from the state, they will come down for the meetings. Very, very strict. This is one of the reasons why you see the maternal mortality like go down, one of the reasons, many reasons, one of the reasons. So there are KPIs, but whether all of them have been taken into account in the remedial process, because once you evaluate something, by right, there's a circle, right? Your circle, so you must do remedial actions and then audit again and so forth. So that sort of scenario, I'm not sure. I have never audited them before, but I do think that they do majority of that. They do think remedial measures, but I don't think it's 100% all the way. In the private sector might be less because the burden is a bit smaller compared with the public sector. But at the national level, they actually discuss this. It's stable in the national level as well. I'm not saying that they are the best, but I do agree there's areas of defect and defunct. They need to monitor that, but they are already measures on how to improve and collating the KPI. The KPIs are very traditional. Example, if you have a wound injury, the patient come back with the same problems, whether any wound breakdown within the next 24 hours, if not mistaken. So there's certain KPIs for public health, for clinical, surgical, and so on, labs and so on. For NCDs, there's none at the moment. NCDs, there's none. So NCDs are being monitored more in the clinics as well. But the clinical aspect, probably the clinician would better say that. But in the sense of public health, we don't really have that as a measure. But I think the clinical part would be.
There are some KPIs, for instance, at the state level, they want a certain proportion of patients to have their blood test HbA1c to be below a certain level as targets and that sort of thing. But invariably, it may not translate to what you want because so at hospital level, you will tend to discharge those who perform well and you get referred those who are performing badly. So I think it's very hard for at the hospital level to achieve any form of KPI because our job is to see those patients who are most complex, most difficult. So in that sense, the KPI is there as a guide as to what you should be achieving and to see your performance, are you getting there? But when you report that I'm not achieving the KPI because I'm not getting enough, funding for drug ABC, unless you have the remedial process, you can't really take the action you need to bring the figures down. So that's our limitation. The KPIs are there, but our ability to act on it is a bit limited because of the funding issue.
Yeah, so the NCDs are based on diseases specific, example diabetes. Yeah.
Well, thank you. Just gonna wrap up very quickly. You have one more final question. Let me get this one.
Hello, Assalamualaikum to all panelists. My name is Dr. Sufi. I'm one of the students in UKM, Doctor of Public Health student. I have one question. With the current brain drain and highly workload of medical officers, house officers, this one I want to ask in terms of what is your pandangan in terms of health economics. Sejauh mana idea of task shifting, dengan kata lain, AMO, Assistant Medical Officer, can do the phlebotomy, echocardiogram, so that the workload of medical officer or officer can be reduced. Apart from that, we also can cut costs in terms of hire more doctor, or we can we can demand in terms of hire AMO, all these medical assistant. Berdasarkan pembacaan saya, negara lain juga telah buat seperti Singapore in terms of echocardiogram, UK, US in terms of helping GP in terms of specific procedure, dan sudah tentu isu kualiti mereka dipersoalkan, tapi kita juga boleh pantau in terms of credential and privileging, CMP. So soalan saya, sejauh mana task shifting ini boleh mempengaruhi our healthcare funding, mungkin boleh cut cost supaya kita boleh capai is better healthcare funding. Thank you.
That's a really good question because we're talking to this doctor who's probably the next generation of our doctors, right? And where we are, we've got to look at that. And so I don't know who wants to take that question. Hang on a second, just get this one as well.
Hello, thank you everyone for organizing. I'm Paramjit. Regards to private, we have done a lot going privatizing in government. All right, so we have set up GLC. All right, GLC's focus is supposed to be focused to the government. This is very much public finance, but instead they are more concerned about the CEO or top management of their perks. So how can government bring some of this fund to help out in other sectors? All right, and for another thing, since we are reducing subsidy, which is a good thing, this is very much for maybe Dr. Jeyakumar or Prof. Jomo. How are we looking at member of parliament to be reduced or cut off their pension? Thank you.
Yeah, I think that one will be Prof. Jomo or Jeyakumar. But Dr. Azraai, maybe.
We already have the expertise, and if you look at most hospitals, for instance, echoes are done by trained medical assistants. We have in hospitals which do not have house officers, and the nurses are doing the phlebotomy. So actually, in some more rural areas, the medical assistant play a very prominent role. in delivering the healthcare. The issue is we don't only have a shortage of doctors, we also have a shortage of nurses. So when I floated the idea of having, dedicated phlebotomies made of nurses, the issue became that we're competing the nurses' time for other things. But remember also that the nurses are doing a lot of administrative duties. Many wards do not have any clerical support, so the nurses have to do all the registration, the paperwork. So actually, one thing that I think if you go further down the line, what we really have is to have more of the administrative support staff. Then you get into the issue that the government cannot afford to hire more staff. But if you look at it from an economic perspective, it's better to hire more administrative staff so you free up your clinical trained workers to do what they're trained to do. So that I think if you go down further down the line, that's where we need more administrative support workers, especially in busy hospitals where the nurses are really doing 3 jobs at once. But yes, we do have trained medical assistants.
Dr. Jeyakumar, you want to get part of this question?
Yeah, Paramjit, I'm a ex-MP and getting pension. I think you got to look at it very clearly. I think a lot of people are quite frustrated with our politicians and say, why is guys getting so much money? Yeah? But you see, if you want to get people to give up their career and go into politics, then what kind of people you get if there's not going to be no pension at all? I was a government specialist, and I had to resign from government service to go into politics, and then I lost the first time, couldn't come back to government after that, and finally when I won as well, I had to give up my clinic as well. I was almost full-time politician. So you give up, your earnings and building your career as either a doctor or an engineer or a lawyer. So if you then have no pension at all, what are the impacts? Would you tend to then see how you can make money while you're in your office? Because you got to feather your nest so that, when you may lose after 1 term, 2 terms, but you're going to have no pension at all. So I think you got to think about that as well. I mean, if you want to say you can't have multiple pensions, as Adun, then you were Exco Negeri, then you were MP, and then you were minister, and all that you add on, agreed. That one fine. But at least one pension, I think, makes sense. Otherwise, you're going to have other morbid kind of things coming up. First of all, people won't want to go in. People doing well in their career will not want to go into politics because you're giving up. And the other thing is the corruption part of it. So I think you need to look at it carefully. What do we really want?
Prof. Jomo?
I really don't have much to say on this subject. But I would simply say that I think the largest issues which we are trying to address today are the question of funding of healthcare financing. Okay, and the fact of the matter is that there has been a declining tax revenue relative to economic growth, and this has basically penalized the health sector, particularly the public sector in health, and has inadvertently driven people to the private sector. It's not clear that we are definitely. We may have a situation where private healthcare is thriving. Doesn't necessarily mean the people as a whole are doing better, are better. And I think this is the big problem, this shortfall. So I think I hope today's session and other sessions which you all are organizing will help to clarify some of these issues, because this is the basic problem which we have. But I think we are running out of time, so let me stop here.
Thank you so much. Thank you so much, panelists. I'm going to hand over to Prof. Chan here.
Okay, folks, I think you've noticed that this has been a very ceremonial light event, okay? But unavoidably, we have to perform the bare minimum, okay, of ceremonial. And what we have here, okay, in appreciation for the participation of panelists and moderators. Okay, okay. We have tokens of appreciation in the form of book gifts. Okay, book gifts, biographies, autobiographies of prominent medical personalities who really should be much better known, okay, in Malaysia. Okay, and so we will be distributing copies of these volumes. Okay. Now I apologize in advance. Okay, probably some of the panelists already have copies of these books. Okay, but doesn't matter. Okay, because these personalities, these books deserve to be more widely distributed, and the personalities deserve to be better known. Okay, so if you already have copies of it, you can give it as a gift to somebody else. Okay? So let me begin. The three personalities are Dr. M.K. Rajkumar, Ang Swee Chai, Dr. Ang Swee Chai, Dr. Wu Lien Teh. Okay? Yeah. So Sharifah, I give you first choice of the three books. Which one would you prefer? Jeyakumar. Rajkumar. Rajkumar. Common hero. Written and compiled by Taxation. The local population is. Okay, who wants to go next? Right? Yeah. Okay, so. Well, in that case, if you want to leave it to that, leave it to. Don't leave it to me, okay? The others will have a choice first and you can answer. Okay, the plague fighter. Dr. Wu Lien Teh. Photo off. Okay. Jomo? Wu Lien Teh. I was told by Grab that I have this, there's a price that the handbook, they're offering at the same price as the paper. So, good value. Okay, that's the remaining copy of M.K. Rajkumar and Ang Swee Chai. Manvir? Oh. I hope you have a copy of this already? Okay, great. Yeah, this is great, man. Yeah. Okay. I kept a copy of Ang Swee Chai. Okay. So I have my own copy. I'll give it to my niece again. Okay, thank you very much. Please remember again that we very much appreciate the feedback again on this, right? And I'll get it over to you in some form, but the thing is very fast. Again, the raw footage of this live stream will be on the Facebook.com. So with that part of it, so it's just about 5 minutes. Photo with